Hello, I'm Dr. Abdul Rahim Baksh, and I'm going to be sharing this presentation, this abstract on this interesting case. It's a case of a significant pericardial effusion, which brought a patient to our hospital. So this patient was an elderly gentleman. He was in his early 70s. He had a background of familial Mediterranean fever, with his previous attacks manifesting as joint aches and fevers. And he had been diagnosed with this about 15 years ago. But this time, he presented to us with complaints of atypical chest pain. The chest pain was described as a sharp pain, which was more positional in nature. It was worse on lying flat. His background, apart from familial Mediterranean fever, he had hypertension, for which he was on losartan, and he'd been on aspirin for long term. Along with the above symptoms of chest pain, he was also having subjective fevers, and he was feeling fatigued and washed out for a week. So on examination, he had a stable blood pressure in 120 systolic. He was apyrexial. There was no distension of the neck veins. His JVP was not elevated. There was no pericardial rub, and the heart sounds were not muffled. They were well audible. And clinically, he was not in heart failure. He was evolemic. There was no pedal edema, and the rest of his examination was unremarkable. So this is his 12-lead ECG on admission, which is a pretty, on first glance, it looks pretty non-specific, but on closer inspection, you probably can say there are some saddle-shaped ST changes in the anterior leads. Otherwise, nothing significant. His blood test showed a white cell count of 12.2 and a markedly raised CRP of 194. Serial troponins on measurement were negative, and his chest X-ray was normal. But because he was complaining of this atypical chest pain, we decided to do a CTPA, which didn't show any pulmonary emboli, but it did show a noticeable pericardial effusion. So therefore, we went ahead and did an echocardiogram. On the echo, now I apologize, we don't have any moving images, but these are the images we obtained. And you can appreciate that on this pasternal long axis, there is a significant effusion. We measured it at around 2 centimeters, and this effusion is present globally. You can see it's here on the subcostal view and on the short axis view as well. It was a global circumferential pericardial effusion, and actually there was also right atrial diastolic collapse, and there was respiratory variation with mitral tricuspid inflow velocities. So all in all, the echocardiographic findings were suggestive of a significant pericardial effusion. Now, the question was, how do we manage this effusion given these echocardiographic findings? So the question is whether we drain it or manage it medically. Now, because the patient was hemodynamically stable, we decided to manage this conservatively. And the patient was started on colchicine 500 micrograms. Now, he wasn't willing to stay inpatient, so we gave him a follow-up closely in 1 week with advice to come back if he felt unwell. And sure enough, a week later, you can see that the effusion has now come down significantly. You can see on the left, it's the admission echocardiogram, and on the right, it's the follow-up 1 week later. And the pericardial effusion in both long parasternal and long axis and subcostally is much, much less. Clinically, the patient did very well. His chest pain subsided. He felt much better, not having any more fatigue or subjective fevers. And we followed up this effusion with an echocardiogram 8 weeks later, and you can see that the effusion has almost entirely subsided. So there was no recurrence of effusion, and therefore we gave him a plan to continue on colchicine for 3 months. So essentially, this case shows that you can manage a significant pericardial effusion associated with familial Mediterranean fever conservatively in the beginning, if the clinical situation allows you to. We stress that pericardial effusion is a known manifestation of familial Mediterranean fever, and colchicine is an effective treatment for serositis that happens with familial Mediterranean fever. There are case reports where the effusion associated with FMF can be very massive and causes tamponade. This can get worse as well, so that's also an outcome. And finally, the clinical picture is very important. Good history and good clinical examination are cornerstones when you're evaluating causes of chest pain, and a cardiac tamponade is a clinical diagnosis. That's the end of my presentation. Thank you.
Hello, this is Dr. Sendil Rastamaswamy from the Institute of Cardiology and Research Center, Ahmedabad, India. So I am presenting my abstract. Do risk scores predict the length of hospital stay in STEMI patients after doing a primary PC? So the background is accurate identifications of patients with highest clinical risk will help in identifying patients for safe early discharge after primary PC. We all know that there is a high burden volume center. The availability of beds is an issue. So to decide on how long should a patient stay comfortably and safely after primary PCA should be decided. There are no proper guidelines, and if there are recent guidelines in the system in 2017, the evidences are very minimal. So we started this study. We analyzed selected parameters and risk source in STEMI patients treated with primary PCA in predicting the prolonged hospital stay. So the purpose was to assess the parameters and risk scores that can prolong hospital stay following primary PCA in STEMI patients. So the methods is a prospective observational monocentric study which included 222 STEMI patients who were successfully treated with a primary PCA using a drug-eluting study within 24 hours of symptom onset with a final TB flow of 2 or 3. So the available risk scores, the validated risk scores like TB score, GRACE score, SWAL score, and Cadillac score are calculated for all patients from the baseline clinical data. The routine blood investigations along with BNP was done for all patients. The entire cohort was divided into 3 groups based on the length of hospital stay. The patients who had stayed less than 3 days comprised of 150 patients, and patients who stayed 4 to 5 days comprised of 47 patients, and more than 5 days comprised of 25 patients. So the logistic regression analysis were used to determine independent predictors of factors that prolong the hospital stay. So the results showed that patients which following parameters predicted the long hospital stay. So eGFR, LVEF, hemoglobin, total leukocyte count, creatinine, troponin, random blood sugar, CK, BNP, and the risk scores, GRACE score, TB score, SWAL score, and Cadillac score. The GRACE score, TB score, SWAL score, and Cadillac score had a significant p-value of less than 0.001, and the odds ratio was for base score it was 1.02, T score was 1.35, and zone score was 1.26, and the Cadillac score, the odds ratio was 1.24, creating an odds ratio of 2.51. So the BNP also had a good prediction for a prolonged hospital stay. It was on 1.003. So the conclusion is the TIMI, PAMI, Cadillac, and Brace clinical models are an excellent tool in predicting prolonged length of hospital stay in patients who undergo primary PCA. Addition of BNP to standard risk scores can increase the predicted risk scores. Thank you.
Hello, everyone. I hope you can see your screen of the poster. And thank you so much for giving us your time to listen to our case presentation. I hope this will be informative and engaging. And in this presentation, we're going to be discussing a case of Takotsubo cardiomyopathy in a comatose patient. So as you may all be aware, Takotsubo cardiomyopathy is a transient wall motion abnormality of the left ventricular apex, and it's associated with emotional and physical stress. And in the setting of a diabetic ketoacidosis, is thought to be caused by the compounded effect of a catecholamine surge and a noxious effect of ketones that leads to a myocardial stunning. So our case is the case of a 73-year-old female. She presented to the emergency department with a 3-day history of progressive fatigue, a poor appetite, loss of sensorium, nausea and vomiting, and a past medical history of hypertension and poorly controlled diabetes. On initial evaluation, she is very lethargic, drowsy, not responding, a low GCS of 6 out of 15. And the initial laboratory investigations revealed diabetic ketoacidosis and hypernatremia. An EKG was performed that revealed an inferior lateral STEMI, which we can appreciate in figure 1. And troponin studies showed an elevated troponin at 10.61. An echo and CT angio were done as well. The CT, the coronary angiography showed no coronary obstruction, and the echo showed features suggestive of Takotsubo cardiomyopathy, which led to her diagnosis. The hospital course was very complicated. She had a low GCS despite correcting the acidosis and the electrolytes. The MRI showed subcortical white and gray matter infarcts and panventriculomegaly. An EEG showed encephalopathy, and a nerve conduction study also showed severe length-dependent sensory motor axonal neuropathy consistent with a diabetic polyneuropathy. The patient was later discharged in home nursing care with physiotherapy, following nutritional requirements and peg tube maintenance, and on medications including ceftriaxone, pantoprazole, calcium carbonate, and insulin glargine and aspart. And now we'll move on to the discussion and conclusion of this case.
Okay, so hello everyone. So after performing an extensive literature search, we've come and highlighted several important parts from our discussion, and I'll go through those in the form of bullet points. So the first one being the sympathetic surge may be compounded by other factors such as ketoacidosis or endothelial dysfunction due to estrogen deprivation. This is usually seen in postmenopausal women, as was our patient. Another point would be that autonomic neuropathy in diabetic patients is known to usually decrease adrenergic stimulation. And so that in mind, this could possibly exert a cardioprotective effect on the development of TCM. Additionally, our patient presented with classical findings of Takotsubo, the echo, the ECG, the elevated troponins. However, in view of her persistently low GCS, she was unable to report the classical ACS-like symptoms of Takotsubo, that being chest pain or diaphoresis, for example. Also, some risk factors such as hypertension and type 2 diabetes may predispose to cardiac remodeling, and in the setting of acute stress such as DKA or hypernatremia, this may actually precipitate sudden cardiac decompensation. And finally, therefore, a high index of suspicion should be held in acutely ill patients with features of TCM. This brings us to the conclusion of this report and the discussion, which would be that there is a need for continuous monitoring and early recognition of TCM features, especially in patients who are acutely ill or comatose or unable to communicate their symptoms. And this is in order to prevent debilitating complications such as arrhythmias or electrolyte imbalances, thromboembolic events, or even cardiogenic shock. Thank you very much for tuning in to our case presentation.
Thank you.
Hello, dear colleagues. I'm very glad to have the opportunity to demonstrate the results of our experience in performing balloon pulmonary angioplasty in patients with chronic thromboembolic pulmonary hypertension. For the first, let me remind the definition of the step, and it's a precapillary pulmonary hypertension, which is diagnosed after 3 months of effective anticoagulant therapy in the presence when the mean pulmonary pressure more than 25 millimeters and pulmonary capillary edge less than 15 millimeters. More than one zone of discrepancy in ventilation perfusion lung scan and specific fissures step on CT angiography or angiopulmonography. And the question is quite relevant because the percentage of survivors after 3 years is less than 20. The morphological variant of the lesion determines the method of treatment. There are the following types of lesions: proximal, distal, and peripheral. In the proximal type, when the large diameter arteries are affected, the main branches and lobes indicated the thrombectomy. If the branches of the segmental and subsegmental levels are affected, recommended performing balloon angioplasty. And with the peripheral type, where the small diameter capillaries defeated, the patients can only be satisfied with drug therapy, medicamental therapy. In the distal type are distinguished the main types of stenosis: ring stenosis, intravascular webs, and occlusions. In 2012, an article by a Japanese professor Hiromi Matsubara was published about their 6 years experience of performing the procedure on 68 inoperable patients. He demonstrated a significant improvement in hemodynamic parameters with a lower percentage of complications. Most Japanese studies demonstrate decrease in pulmonary hypertension functional class, pressure in the left pulmonary artery, pulmonary vascular resistance, and increase cardiac output. The accumulated experience allowed Japanese colleagues in their local recommendations to raise the class of recommendation to the level of thrombectomy to 1C. This slide demonstrated how the lumen of the affected arteries changed after BPA. There is a lesion by the type of intravascular webs, and pay attention how small the diameter of the effective lumen of the artery is 2.5 millimeters square, with an artery diameter 21 and 6. After angioplasty, rupture of these webs, the effective lumen of this artery increased to 20 millimeters square. What also noticeable for the angiographic picture, blood flow in the periphery improves. Here is a schematic representation of what's happening to the artery. After the restoration of perfusion in the target arteries, the thrombotic masses are pushed sideways and a neoantima is formed in the new lumen. A clinical example of our successfully treated patient. We see angiographic pictures of the right pulmonary artery in front and lateral projection and left. As you can see, it's important to open occluded branches as much as possible. See how the dynamics of hemodynamics parameters change from stage to stage. The pressure in pulmonary artery decreased. Pulmonary vascular resistance is normalized, and the 6 min-volt distance is increased. Now about how many arteries need to be treated in one stage. If earlier, 3-4 years ago, was not recommended to treat more than 2-3 arteries in one lesion, today, thanks to the accumulated experience, the concept has changed. Look at this table. Surgeons are divided by levels into beginners and experienced. But it's clear that it's matter beginners should also be as experienced surgeons as possible. And this approach is confirmed in other new article. The point of that dilatation of a larger number of segments was stated with a large decrease in mean pressure, and treatment of only 1 or 2 segments per procedure is not sufficient. To achieve a sufficient reduction in pulmonary artery pressure, we need to treat as many arteries as possible in a limited time and with a little contrast as possible. Also, over time, remodeling of the right chambers and the treated arteries increased in diameter. This slide is technical, and there is most frequent catheters, balloons, and wires are shown. Now, a few words about complications. The most common complication is reperfusion edema, occurs in about 20% of cases. 12 hours after successful recanalization of occlusion, happened a cough and the saturation of peripheral arterial blood up to 88%. On the CT, there is a picture of 4th degree reperfusion edema of the lower lobe on the right. After non-invasive lung ventilation, oxygen therapy, forced diuresis for 2 days, the patient's condition improved. Pulmonary edema was stopped. There is a basic principles of treatment of reperfusion edema. And perforation of or rupture of the pulmonary artery is the most serious complication of balloon angioplasty. And the frequency is reported up to 7% in recent studies. Pictures from internet, and there is a possible methods of hemostasis are proposed. Perforation and ruptures occurs during dilatation when the wires pass through the occlusion area extra or paravascularly. In order to make sure that the wire is in true lumen and safely perform the BPA, we have proposed a simple but effective technique. Bronchial artery catheterization is performed from the operated site, and during angiography, we see retrograde filling of the periphery of the occluded branches. After you are convinced of the correct position of the wire, you can safely perform dilatation of the artery. We recently published these techniques in the Journal of American College of Cardiology. This is a clinical characteristics of our patients. In just 6 years, we have operated on 80 patients in 318 sessions, 55% of men, and the most frequent risk factor is massive pulmonary embolism in anamnesis. As you can see, the functional class of pulmonary artery has pulmonary hypertension has improved in patients. The 6-min wall distance has increased, and the parameters of right chambers and pulmonary hemodynamics have improved. Conclusion: selection of patients and surgical intervention should be performed in an expert center with the cardiac surgery department. Balloon pulmonary angioplasty is effective and relatively safe procedure. subject to the algorithm of selection of patient and the methodology of the procedure. The decrease in pulmonary artery pressure and pulmonary vascular resistance established the positive dynamics of the right air chamber remodeling. Transbronchial guidance for balloon angioplasty reduced fatal complications. Further research is needed to develop optimal tactics of surgery in order to reduce the percentage of complications.
Hello, dear colleagues. Let me introduce our presentation. So the name is staging of the inferior vena cava and the iliac veins in the patient with hormone disease and renal insufficiency. We are from Volinskaya Hospital from Moscow. My name is Alexey Pankov. As we know, retroperitoneal fibrosis is a rare disease that occurs due to non-specific inflammation of the retroperitoneal tissue with the formation of the fibrous tissue that causes compression of the ureterus, inferior vena cava, and other nearby structures. So, patient 83 years old was admitted to our hospital with edema and venous ulcers on his lower extremities. He has nephrectomy in 2007 after terminal hydronephrosis of the right kidney due to retroperitoneal fibrosis. Over the past 4 years, surgeons are replaced with a ureteral stent in the left kidney every 8 months, and the creatinine level is kept in the range of 1.6–1.7. The syndrome of the inferior vena cava was suspected as a result of compression of fibrotic retroperitoneal tissue. Unfortunately, it was not real to do CT angio with contrast due to high creatinine level. According to MRI data, the strongest compression is localized in the confluence of the right and left common iliac veins and the inferior vena cava. IVC is measured for long lengths, including the intrahepatic segment. But how real is this? In addition to stenting both common iliac veins, doing long stents for total stenting of IVC. During the direct phlebography, 20 milliliters of the non-ionic contrast was used. The creatinine level remains unchanged. It is confirmed that the strongest compression is localized in the confluence area of IVC and both common iliac veins. Further diagnostic was performed with the help of IVUS. So we see the IVUS data, right and left common iliac veins, it's really big, but in the center we see that the IVC obstruction is very strong and the confluence area. The most important thing is the IVC 4 centimeters above the confluence zone is also narrow due to retroperitoneal fibrosis, but stenting in this zone is not required. So the stents can be placed below the level of the left renal vein. And 6 months later, we perform second stage. The first is a balloon angioplasty confluence area. And then, according to the double barrel technique, 2 stents with dimensions of 14 to 120 millimeters were implanted with the final kissing dilatation. And in the slide, we see the final result. We see the very good flow. In the slides, we see the final IVUS from left common femoral vein to the IVC. We see the good expansion of the both stents. And in this slide, we see IVUS before and after stenting, then the cross-sectional area in the IVC in the confluence. Before stenting was just 23 square millimeters, and cross-sectional area after stenting is grows 10 times. It was 242. Yeah. So this is the one stent, the second stent, and the IVC. The entire operation took place exclusively under the control of the IVUS. But in the end, we made a final angio, as you see it, with 50 millimeters of the non-ionic contrast. Since 2 days after the operation, creatinine level rose to 1.95 with a slight decrease in diuresis. Fortunately, a day later dropped to the original 1.7. A month after the operation, the patient notes a decrease in swelling of the lower extremities and gradual healing of the ulcer on his left leg. Thank you for your attention.
Hello, my name is Alexander Predenchuk, and it's a great pleasure to present our results of early diagnosis and treatment of compartment syndrome in patients with non-traumatic acute lower limb ischemia. Compartment syndrome is a typical complication of acute limb ischemia with an incidence of 20–30%. Fasciotomy is a single effective treatment for compartment syndrome. The aim of study was evaluation of factors associated with development of compartment syndrome and impact of early fasciotomy upon the results of revascularization. During 2019-2021, 142 consecutive patients supposed to revascularization for non-traumatic acute limb ischemia were prospectively enrolled and followed up for 3 months. Routine clinical workup for acute limb ischemia was complemented by infrared foot thermometry with calculation of forehead to foot temperature gradient. Compartment syndrome was suspected clinically and confirmed by measuring intracompartmental or perfusion pressure. In all patients with compartment syndrome, four-compartment fasciotomy was performed simultaneously with revascularization. Study was approved by local ethics committee. Our results: compartment syndrome was diagnosed and treated in 23 cases. The resection of non-viable leg muscle was required in 5 cases, mostly in anterior compartment. Patients with compartment syndrome were more frequently diagnosed with grade 2B acute limb ischemia, 20 versus 63 cases in patients without compartment syndrome, and had a high level of myoglobin. The most significant difference was found in the rate of limbs with forehead to foot temperature gradient that was more than 10 degrees, 16 cases in group with compartment syndrome versus 30 in controls. Temperature gradient was independently associated with presence of compartment syndrome in multivariable analysis. There was not statistically significant difference between groups regarding patient age, duration of ischemia, site of arterial occlusion, and level of creatine kinase. During the follow-up, entire cohort major amputation was registered in 30 cases and death in 25 cases, without significant difference between compared groups. In conclusion, early diagnosis and treatment of compartment syndrome can mitigate its negative impact upon the outcomes of treatment of acute limb ischemia. Forehead to foot temperature gradient can be used as adjunct for clinical diagnosis of compartment syndrome. Thank you for your attention.
A very good day to you all. My name is Dr. Vishal Agrawal, and I'm currently working as a second-year postgraduate medical trainee in the Department of Cardiology at Liverpool Heart and Chest Hospital in the United Kingdom. I'll be talking to you about my quality improvement project titled The Impact of Formal Teaching on the Interpretation of Radiological Imaging in Healthcare Professionals. As the field of medicine has progressed, radiological imaging has gained prominence as a key prognostic and diagnostic tool in all fields of healthcare. It is therefore important for healthcare professionals at all levels to have a degree of proficiency in their interpretation. So, why did we do this project? It was done primarily to assess and improve the radiodiagnostic skills of medical professionals out of hospital hours, particularly those involved in seeing medical referrals in the emergency department and from the GP at a large teaching hospital in the UK. Tell me, and I forget. Teach me, and I may remember. Involve me, and I learn. These are some wise words said by Benjamin Franklin a long time ago and are still relevant to this day. The idea was to first assess how confident junior doctors and advanced clinical practitioners at various levels were at interpreting images, involving them in deciding what kind of teaching would best suit their learning needs. After that, in order to start a quality improvement cycle, the aim was to provide teaching based on this data, get feedback on the teaching delivered, and use it to further fine-tune the curriculum. This is the forgetting curve. Developed in 1885, this was the outcome of a landmark research project that showed that there is an exponential loss of memory unless information is reinforced. There are 4 key elements to learning: attention and focus, connections, associations, consolidation, emotions, and spaced repetition. So, how do we go about achieving our aim? First, we took a survey to obtain our initial data. Based on this result, we devised a teaching curriculum of 3 sessions. We used various teaching methods, for example, face-to-face interactive learning with online participation. We ended with a final quiz. Feedback was collected at each step to define and refine the next step. A total of 127 forms were collected. The attendees were of various levels, starting from junior doctors in their first year of practice, all the way to postgraduates. Here's the data. I'm just kidding. The gist of it is that a majority of the trainees were doctors who had more than 1 year's experience after medical school, but had not yet attained their MRCP diploma. 37 participants attended all the sessions. The questionnaire had the following key questions. How happy are you with your current working knowledge in the interpretation of X-rays? On a scale of 1 to 5, 1 being the least and 5 being the most, how useful did you find this session? How often do you independently make comments on X-rays out of hours? After this session, how confident are you in the X-ray interpretation skills? In addition, it had questions about how the session went, whether they liked the format of teaching, what topics they would like to learn about in the next session, and from whom. Let's now take a look at what data was obtained as a result. Coming to the first question. The quote, average happiness at the end of 3 sessions was 20% higher than it was before the first session. Second, the average usefulness of a session was 84.4%. Third, there was a 43% higher likelihood of the attendees to make independent comments on X-rays out of hours. That is, when there was reduced supervision. Fourth, there was a 29% increase in the average confidence in X-ray interpretation. So, to summarize, 20% increase in happiness, 43% increase in likelihood, and 29% increase in overall confidence. To conclude, this study stresses the importance of continuous learning about all aspects of medicine and how different departments can work together to increase the quality of patient care. Currently, there's not enough of an emphasis on the importance of formal radiological teaching. In an age where imaging is developing at a rapid rate, this study showed that the formal teaching sessions can make a significant difference in a clinical setting. Thank you for your time. Normally, I'd ask if anyone had any questions, but since this is a pre-recorded event, please feel free to email me on the address on your screen.
The study I will be presenting is a molecular in vitro study on the expression of the protease-activated receptor 2, or PAR2, in a preclinical rodent model of statin-induced myalgia, which is an experimental study. Let's start with the background of our study. Hypercholesterolemia is a major health concern affecting almost 1/3 of our population. People often overlook and ignore their untreated hypercholesterolemia, thus leading to other health conditions, and this is a major reason for cardiovascular diseases. The approved medical drugs used for treating hypercholesterolemia are called statins. Of course, like every other drug, statins have side effects. And the main side effects that people complain from is muscle pain, which is the main reason for patients' non-compliance. Part 2, the receptor we are studying is a G protein coupled receptor that is found in many body tissues and muscles and is found to be activated during the development of chronic pain states. Our aim is to study the expression of the Part 2 receptor and find out whether it is involved in statin-induced myalgia. The first objective of our study is to localize the Part 2 expression on the nerve terminals of the gastrocnemius muscles and compare the level of expression of Part 2 between the statin-treated animals versus the control animals. The second objective is to quantify the mRNA levels of Part 2 proteins in the dorsal root ganglia of L4 and L5 and compare the expression between the statin-treated animals versus the control animals. As for the methods, we started by administering the types of statins, two types of statins, simvastatin and rosuvastatin, to the rats over a 30-day period. Later, the tissue is excised from the gastrocnemius muscles and the L4, L5 dorsal root ganglia. This tissue was taken to the lab where we used two techniques to try and find results. First, we performed the fluorescence immunohistochemical staining, where we checked our results under an upright fluorescence microscope. Second, we quantified Part 2 mRNA using RT-PCR, and we compared the expressions. This moves us to our results. The first graph on the left shows us the percentage of fluorescent cells expressing Part 2 for L4 and L5 DRG tissue, and comparing them between our control and our statin-treated animals. We observed that with the simvastatin-treated animals, the percentage fluorescence was significantly greater than the percentage fluorescence expressed with a control group. We can visualize those results by looking at the two images in the middle, which show us the increase in fluorescence in simvastatin-treated animals when compared with the control. Finally, for the RT-PCR method, we observed that the simvastatin-treated animals showed us a significantly lower threshold cycle number than our control group, meaning that Part 2 is expressed more when the rats were treated with simvastatin. In conclusion, our study showed us a significantly increased expression of Part 2 in the L4, L5 DRGs and gastrocnemius muscle tissues for simvastatin-treated animals. However, no significant change was seen in rosuvastatin-treated animals. As a possible implication in the future, Part 2 could potentially be the target of pharmacological drugs that aim to reduce the statin-induced muscle pain.
Dear colleagues, it is a great honor for me to share with you by my experience in the care out of patients with peripheral artery disease, especially in this difficult era when the population all over the world is suffering from COVID. My name is Vladislav Derkich, the head of the Interventional Cardiology and Radiology Department. Many authors in their publications show the negative impact of COVID not only on lung tissue, but also provide the damaging effect of the virus on kidney function, which increases with each new strain of COVID. Moreover, in performing interventional studies or treatment procedures using iodine, kidney function may also suffer. So, the option for treating peripheral arteries disease in patients with chronic kidney disease are limited. We propose an alternative method of vascular imaging without iodine in patients with critical lymphemia. I wish to show our first experience in Russia in implementing the technology zero iodine and offer a learning curve of a specialist for maximum implementation of this method. Now, our experience of using carboxyangiography is more than 100 patients with iliac, femoral popliteal, and tibial artery disease. This poster demonstrates the possibilities of diagnostic CO2 angiography in a patient with multi-level arterial disease after previous peripheral bypass. Diagnostic and therapeutic interventional procedures were performed to 104 patients with critical low lymphemia. According to ultrasound, stenosis or occlusions of the arteries were located below the inguinal fold. 104 diagnostic procedures and 71 interventions were performed. All interventions were performed with Philips Allura FD20 using DSA system and CO2 special Philips software. The introduction of carbon dioxide into the arterial bed was carried out using the automatic injector Angiodroid. In results, complete success when we use less than 1 milliliter of iodine was achieved in 83 patients out of 104 diagnostic procedures, often zero iodine, and complete failure more than 20 milliliter iodine in 4 diagnostic and 1 intervention procedures. So, carbon dioxide can be considered as a real alternative to iodine contrast agents, both in diagnostic angiography and in performing interventional procedures like angioplasty and stent placements in patients with critical lymphedema. Replacing the use of iodine with CO2 as the only contrast substance in critical limb ischemia patients is a safe and effective method. This technique plays a special role in patients with contaminant chronic kidney disease and after COVID infections, which significantly aggravate the course of chronic kidney disease. To implement the zero iodine technique, it is necessary to go through the learning curve in the cath lab step by step. It is the most appropriate to start the implementation of carboxyangiography into clinical practice with diagnostic and interventions in patients with femoral popliteal arterial disease. The use of automatic CO2 injector makes it possible to perform angiography and percutaneous interventions quickly, safely, and comfortably for the patients, while the imaging quality is not inferior to image obtained using iodine contrast agents. When performing diagnostic and interventional procedures below the inguinal fold, the two strategies for using carbon dioxide are applied. The first strategy is aimed at reducing the use of iodine by it replacing with carbon dioxide as some stages of procedures. The second strategy, iodine-free, involves the complete replacement of iodine with carbon dioxide. In our opinion, the choice of strategy for using carbon dioxide should be based on the patient conditions, risk factors for the development of chronic kidney disease or contrast-induced nephropathy, the planned scope of the intervention and its complexity, as well as so on the experience of the surgical team performing the procedure. The desire to perform a diagnostic or interventional procedure using new equipment and without using the usual contrast agents should not override the benefits of the procedure and increase the risk of misinterpretation of angiography results or surgery outcome. Thank you very much for your attention.
Ladies and gentlemen, Mr. Chairman, explantation versus graft preserving strategy following EVAR. Best graft haven't been designed and a lot of lessons have been learned. We conveyed long-term outcome of more than 1,480 patients done by vascular surgeon equally proficient in both open and EVAR using precision medicine with adaptation of graft type, configuration, and post-operative surveillance to maximize individual patient care. Aortic sac hygroma and concealed endoleak after EVAR needs aggressive management, as they are associated with rapid sac expansion and rupture risk. They can be enormously reported as type 4, type 5 endoleak with supine CTA leading to delay in management. Prone contrast enhanced computer tomography, angiography, PASHA documented all concealed endoleak. In synchronicity, EVAR Gore salvage fabric technique or Arafat used to salvage majority of previous EVARs. All EVAR graft failed due to obsolete passé technology. And as you can see from here, you have explained it a lot, I'm sure, and this is becoming a tsunami as 25% of my practice currently is dealing with failed EVAR. And they come with rupture. And when you rupture, you have big surgery, and when you have big surgery, you have to stay more in the ICU. So we need to start looking in a more detailed way to prevent this disaster from happening and use a technology that doesn't make any sense for the current situation. We have published extensively on that, and what we found that a sustained gradual increase in the aortic sac that exceeds more than 7.5 centimeter is an indication for prophylactic intervention, and we have the algorithm ready and it's available on the net to download. What we have done, we have moved from the 4-phase contrast supine CT scan to 4-phase contrast enhanced CT scan in the prone position. We put the patient on his face, the graft is sucked the dye out of the microfabric fatigue failure in the polyester graft, and this allows to shine the aortic sac like a Christmas tree. And I'll show you a few examples. We understand that sac hygroma are slow expansion without evidence of endoleak. Hygroma are linked to transudation from graft fabric to form a jelly-like consistency phlegmon around the endograft. Sac hygroma radial density are less than 25 Hounsfield field unit and are most common in polyester endograft. All newer imaging techniques will detect aortic hygroma. It was neither feasible nor accurate previously. And this is a good example of an aortic sac hygroma. Radial density are less than 25 Hounsfield. The aim of our study, we found that it's a slow threshold of suspicions in patients who present 5-6 years post-primary EVAR with aortic sac expansion who were reported as type 4 or 5. Accuracy in diagnosing by Pasha technique for aortic hygroma or concealed endoleak forced us to explore alternative treatment protocol to optimize management in high-risk patients for open surgical repair and double breasting by performing Arafat, as this patient have been done almost 10 and 15 years ago, and they're coming now in their 90s, and I'd prefer not to open the belly. The objective is to realign the stent graft from polyester to PTFE to seal the micro leaks, to abolish hygroma because of polyester filtration, realign whole graft for better spiral arterial flow. More importantly, what we found that our incentive was ignited by the knowledge that existing realignment technique, in particular Zenith Renew, Cook, or Aort Uni-Elac Medtronic, both are associated with distal migration with resulting type A1 endoleak due to pathological flow pattern as it pull in the graft down by this technique. So the EVAR gold salvage fabric technique, we put an aortic cuff inside the at the lowest renal, and then realign it with 2 short limbs 7 centimeter of 16-16, and then we extend both limbs distally. And this is a completion angiogram of a patient who had an Arafat technique to salvage the problem. We have seen a lot of failures, and this is the Zenith Cook failed with a micro pore that pulsating blood, and this was diagnosed as concealed endoleak. The same exactly for the AFX, and it's because that it's an obsolete technology. I can't believe we're still using this currently now. And then we go in and we start explanting this graft, but the patient gets sicker and sicker in the ICU and stay for a longer time. And we have to look at this complexity of all of these cases when we have to do bypasses to the renals, bypasses to the SMA in order to get a better outflow. So it's a huge burden on the patient. So we've done a primary endovascular management by Arafat. So the patient comes in, have 4 CT scan, you can't see anything. You do a PASH, you could see the aortic sac lighting like a Christmas tree, and then you do Arafat. PASH Arafat are a fully functional protocol to overcome apparent challenges in accurate diagnosis and subsequent concealed endoleak management in high-risk patients. And this is a good example of a patient who have a failed AFX. You could see the type 1 endoleak over there and realigned totally with the new Gore salvage technique. And this is another patient who have another AFX and came in with an expanding sac almost 9 years post-intervention. So we went on and we realigned the whole graft with the Gore graft, and you could see the look in here. It looks strange. You're not well accustomed to the look, but patient, his aortic sac completely resolved, abdominal pain and low back disappeared immediately. And we start reproducing this on and off. And there's a lot of failed polyester graft that require this technique so that you do not explant the patient. However, the aortic sac, there's no other way except you have to decrease the pressure inside the aortic sac. And remember, radial density are less than 25 Hounsfield. And what you go in, management by surgical double breasting of the aortic sac or open replacement with wrapping with biological graft. And the whole idea that this biological graft induces extensive fibrosis into the lymphatic over there to prevent any sort of seroma into the aortic sac, or endovascular lining of the stent graft, they don't do as much as we have done. And you can see in here the Medtronic graft that have been double-breasted over there. And it's becoming more obvious is that this patient, because they have a lot of TPA for their heart attack and a lot of DUAC, that this filtration. Moreover, what we find that even there's no migration. You could see that the stents are perforating through the proximal long aortic neck. The stent is over there, and we have to open it, and you can see the fresh blood inside with signs of embryonic rupture, and we go in and we realign the graft with this biological graft. We have a low threshold for opening the aortic sac. We opt for the evacuation of hygroma and double breasting because of the fear of aortic sac rupture leading to high morbidity and mortality. A 36 millimeter proximal diameter aortic cuff with more than 4 modular components with limb size above 23 millimeter had a higher chance of graft fabric failure, hygromas, and late complication. Majority of polyester-based stent graft systems have been associated with high white cell count and CRP postoperatively, indicating post-implantation syndrome. Post-implantation syndrome following primary procedure has a long-term determinant on endoleak and microfabric fatigue failure. 50 months is the post-operative length of time until presentation to our, so it takes longer time for this problem to happen. A rapidly increasing aortic sac more than 75 millimeter and associated with severe abdominal pain and low back pain with documented Hounsfield less than 25 in a setting of an implanted polyester-based graft is an aortic hygroma until proved otherwise. Reduction in profile of polyester graft to reduce stent graft profile had caused the long-term sequelae of hygroma. This is augmented with the use of DUAC, potent antiplatelet medication, and thrombolysis. Contemporary abdominal aortic aneurysm devices, why the best graft haven't been produced yet. Multinationals have focused on reducing the profile of delivery system in order to make technology more amenable to percutaneous access, thereby expanding customer base to other interventions that doesn't have the luxury of doing cut downs. In their pursuit of market share, they compromise fundamental science behind design of a good endograft and jeopardize long-term durability. Mr. Chairman, ladies and gentlemen, significant sac expansion over a short period requires scrutiny by detailed patch protocol and a personalized approach. Patch protocol diagnosed concealed endoleak type 4 and 5, which weren't appropriately diagnosed by supine CT protocol. A 65 of endoleak type 5 are type 3B fabric fatigue failure. We thought that EVAR will be the solution. However, we start expanding a lot of EVARs and starting reconstructing again. It's back to the future scenario, and we need to improve our techniques. Thank you for the opportunity to present today.
Welcome. Good morning and good evening to all of you around the world. Hi, Dr. Reddy.
Hi, Dr. Varghese. Good evening.
Good
I guess
evening.
it's good morning for us, Saturday morning on call. So pardon my attire.
That's fine. I want to welcome everybody to the third and final day of 4TS 2022. It's been an amazing 2 days of sessions, and we look forward to fantastic lectures and a lot of new information for us. And we're moderating for you all around the world. We're waiting, I think, for a couple of other moderators. Dr. Halleck is in between halls, I believe, so we're going to handle it for him until he comes. Dr. Dash, good evening to you. Is that correct? Or is it good morning? Dr. Dash, can you hear us? Okay, I think he's fixing his computers and all that. So we have a wonderful lineup, right, Dr. Reddy?
Yes, it is.
Great speakers. We're going to talk about... Dr. Dash, there we go. So we have some challenging cases presented today in our Hall A coronary tract, and I want to get started. Actually, Dr. Reddy, you're first, I believe, with OCT mild max algorithm, and then Dr. Hakim, Dr. Dash, and Dr. Majdi, and from USA, UAE, and Egypt. And I know that Dr. Reddy is in the USA. Where are you?
I'm in Dayton, Ohio.
Wonderful. Well, we're going to get started with your lecture first. I
Thank you.
believe if the team is ready, we'll get started with Dr. Reddy, OCT.
Hi, good evening.
Hello there.
Hi, Dr.
Yeah,
Dash.
actually, I'm sorry. I was not able to listen to you. Yeah.
No, you're perfect. You're perfect. We're just getting started with our sessions, and we're going to start with Dr. Reddy. Team, let's get going.
Yeah.
Good evening, everyone. This is Dr. Niranjan Reddy from Kettering, Ohio. I've been tasked to talk about the MLD Max algorithm for this evening. First, I would like to thank the 40S chairman and the committee for giving me this opportunity to present. I would go ahead and start off. The OCT algorithm is a short, simple process where you can follow this algorithm and get good results of an entire study very well. It's based on MLD max. Pre-PCI OCT is to strategize, and the MLD is the morphology, length, and diameter, while the post-PCI OCT study is to optimize what you have done, and you want to look at the medial dissections, if any, apposition of the stent, and expansion of the stent. Before we jump into the algorithm, a quick slide on the normal artery morphology on the OCT. As the picture depicts here, you see the catheter and the wire artifact. The intima, media, and adventitia is well defined on OCT. Intima is the thin layer there, followed by the media and the adventitia. The external elastic lamina is an important thing to note. It's like a rubber band, like gray zone, which is seen in the picture. The reason this is important is you like to measure the diameter of the EEL when it is available to properly size your stent. If you do not see the EEL, you can go ahead and use the lumen and go from there. The first process in the pre-PCI OCT, the MLD, and that is morphology. And morphology, you want to look and see if there is calcium, which is in low amount or high amount, lipidic or fibrotic cores. High calcium is when you have greater than 180 degrees of circumferential kind of calcium with more than 0.5 millimeters thickness or depth and more than 5 millimeters in length. And when you see a high calcium, you want to use your non-compliance balloons, lithotripsy, scoring and cutting balloons, and atherectomies. In low calcium, you can just use your clinical judgment to use an NC balloon or a semi-compliant balloon and then go with primary stentings. This is what you can get from the morphology, whether it is a lipidic, fibrotic, mild to moderate calcium, or severe calcium. There is loss of refringence on the lipidic, while the fibrotic shows a circular kind of ring, and calcium is a well-defined haziness you can see in the vessel. And if it is severe, as you can see on the fourth one, it is greater than 180 and significantly deep. Next thing is the length. You basically want to scan the entire vessel to land your stent in the best perfect landing zone if possible. You want to look for landing in a healthy tissue where you can probably see the EEL better. And as you can see EEL better, you can even measure the size of the vessel better. And you would prefer to avoid landing the stent in a lipidic core to avoid areas like the TICFA or anything, so you don't get edge dissections. So you prefer to land in normal to normal. So you scan the distal segment and the proximal segment to find what is your best area, and then find the length of that segment to match to your stent size. Diameter is the next thing. You want to use the EEL where it is visually good, visible. You want to measure two perpendicular EEL measurements and average that. If you're using EEL to size your stent, you always want to round down to the next quarter size. For example, if the EEL is measuring 3.2 on two perpendicular lines, you want to cut it down to a 3.0 stent. Now, in places where you cannot see the EEL well, you can use the lumen. And when you use the lumen, you go and want to always round it up, go up by quarter size. So if it measures 3.08 on this picture here, you want to take a 3.25 stent. And again, remember that you're using the distal segment for stent sizing rather than the proximal, as you can do proximal optimization technique in the proximal segment. Once you have selected your stent based on your morphology and determined the length and the diameter, you have gone ahead and placed the stent. Now comes the post PCI OCT. After placing the stent, the next run you do is where you want to see how better you can make the outcomes and optimize the result. So MAX, MAX stands for medial dissection, apposition, and expansion. Medial dissection, you want to look at it at both ends, the proximal as well as the distal end. And you want to make sure that a significant medial dissection is one which penetrates medial layer and is more than 1 quadrant size arc. And if you see that, especially in the distal segment, to prevent progression of the dissection, you go ahead and place a stent. Dissection should penetrate medial layer and has to be greater than 1 quadrant arc, and that is significant. In these pictures, you can see a small intimal tear in the first one, and the middle one is the medial dissection, and the last one is a medial dissection with an intramural hematoma, which always requires additional stenting. The next portion of the algorithm on the post-PCI OCT is apposition, how well your stent has attached to the walls. You want to look at the pictures for predominant gross malapposition, which is described as longer than 3 millimeters and greater than 3.3 millimeters or 300 microns from the wall of the vessel. Apposition makes it malapposition makes it difficult for you to get back into the stent if you have significant malapposition in the proximal segment, and you may, when you have to rewire it, you may go behind the stent strut. When you see malapposition, you want to go ahead and dilate it with a semi-compliant low pressure balloon. The next thing is the expansion. If you deploy your stent in a lipidic area, which is not advisable. And if you do it in a normal fibrotic areas or a normal segment, you would want at least an 80% acceptable expansion, if not 90% is optimal. I usually prefer not accepting an 80% only if I'm deploying it in a calcific segment. And if we do not get a good expansion, you want to post-dilate it with a non-compliant balloon. So to sum it up, OCT algorithm MLD max is morphology where you look for calcium if it's greater than 180 degrees, 0.5 millimeters in thickness and 5 millimeters in length, and you want to use NC balloons, IVLs, cutting scoring balloons, or atherectomy. You want to select good landing zones to estimate the exact length, scan for the largest luminal area. You can try to see if you can find the EL, and if you can't find the EL, find the largest lumen and adjust the stent length. Diameter, you want to either measure the EL or the lumen and use the distal reference of the distal area to size your stent, because proximally you can always do the proximal optimization technique. Post PCI, you want to rule out medial dissections. Again, a significant dissection is which is penetrating into the medial layer and is greater than 1 quadrant arc. And if you see that, especially in the distal segment, go ahead and place an additional stent. Apposition, anything greater than 3 millimeters in length and greater than 0.3 millimeters away from the wall is gross molar position, and you want to dilate it with a semi-compliant balloon at low pressures. Expansion, I would prefer to go for 90% optimal. If not, you have to settle for an 80%. Common practice is if you don't get that, do a non-compliant balloon. There's a common thinking that adding OCT to your case will increase time and radiation, but if you do a good OCT, you're getting a 360-degree view of the vessel, and you don't need to do your without wear and with wear orthogonal views and all those things, and that's way you can save some of the contrast and the radiation. I again want to thank you, the 4TS committee and the chairman, Dr. Halak, for giving me this opportunity, and thank you very much. Be safe.
And gentlemen, it's my pleasure to be with you today at the 4TS conference. I'm thankful for the organizing committee for inviting me. I'm Dia Hakim from Brigham and Women's Hospital, Harvard Medical School, and my presentation today is the preemptive PCI for coronary artery disease, identification of high-risk lesion. I don't have any conflict of interest for this presentation, and as you know, current guidelines focus on identification and revascularization of hemodynamically significant coronary artery stenosis. And despite extensive validation of this flow-limiting revascularization strategy in large prospective randomized trials such as FAME trials and the FEAR trial, the event rate after complete revascularization remains relatively high, with MIS rate occurring around 30% after 5 years. Serial angiography and intravascular imaging studies have shown that coronary lesions with initially mild stenosis often rapidly progress in the weeks to months before ACS. And recent investigation demonstrated that preemptive PCI of non-culprit lesion that may not cause ischemia in patients with STEMI reduce MACE. The ischemia hypothesis relating coronary atherosclerosis to major adverse cardiac events. The question is why? It's simply because ischemia is reflecting a high plaque features. And in acute coronary syndrome, most often occur at the site of mild stenosis. As you can see here, almost two-thirds of patients with acute coronary syndrome develop events in the before having the acute coronary syndrome. Will have intermediate plaque between 50 and 60%. Complete trial is an important trial that involved the complete versus culprit-only revascularization to treat multivessel disease after early PCI for STEMI patients in 2,000 patients. And in complete trial, there was a reduction in mix from preemptive PCI of non-culprit region, and it was similar between lesions to ischemia with fractional fluid reserve less than 0.8 versus lesions that were only visually assessed to have luminal obstruction more than 70. What about stable coronary artery disease? Most studies to date have shown that PCI in stable coronary artery disease decreases the frequency of angina and improves exercise without reducing death or MI. That has been shown in COURAGE trial. There was no difference between the optimal medical therapy arm and PCI plus optimal medical therapy arm. And it was also confirmed in the ischemia trial that showed also there was no difference between both the revascularization arm and the optimal medical therapy arm, regardless the number of leads or number of vessels, regardless the subset of patients or subset of disease. The only advantage was that revascularization improved the quality of life and angina status. So the question is, can we identify these vulnerable plaques? And the answer is yes. Using radiofrequency IVUS, NIRS IVUS, and OCT, we can identify plaques that put patients at risk for future events. This plaque is mainly the TICFA, the thin cap fibroatheroma, which is the precursor lesion of plaque rupture. And TICFA definition is the plaque that has huge lipid core, necrotic core, with a thin fibrous cap, so this cap can rupture and cause subsequent thrombosis. And we can detect this plaque by various imaging modalities, by IVUS, by virtual IVUS, where we can see the necrotic core and the circular and the thin cap on the top. On the OCT, we can see the lipid content, and we can measure the plaque thickness. And so by NIR IVUS, which measure the chemogram, the amounts of lipids in the vessel. And this imaging modalities also can detect the other high-risk plaque features like plaque erosion and calcified nodule. In the PROSPECT trials, showed that the miss rate in non-culprit lesion was around 11.6%. Again, those are the non-culprit lesions which we are not paying attention to them during intervention. We are concentrating mainly on the ischemia-producing lesions. And in PROSPECT trials, by multivariable analysis, the high-risk features of the high-risk plaque were the plaque burden more than 70%, the VH TICFA, and the minimal luminal area less than 4 millimeter. And when we put this risk features together, they are synergistics. It means when we have those three features, we have a miss rate up to 17.2%. Besides the anatomical features, we have the biomechanical features like the endothelial shear stress, and when we add the biomechanical features to the anatomical features, the miss rate will increase to 52%. The PROSPECT 2 trials used another imaging modality, the NIRS IVUS, to detect the high-risk plaque and to see to study the progression of this high-risk plaque difference between the culprit and the non-culprit lesion. And in PROSPECT 2 trial, the miss rate was 8% in the non-culprit lesions. And again, by multivariable analysis, the variables were the maximum lipid core index more than 3 to 4, the plaque burden more than 70%, and the minimum luminal area less than 4. This is a case, a representative case from PROSPECT 2 trial. As you can see here, in the proximal RCA, there is a lesion, which is a non-culprit lesion, which is not the lesion that we will fix during PCI. And by chemogram, this lesion has a high lipid content. And look at what happened after 3 years of this non-culprit lesion with high lipid content, which is a high-risk feature, progressed to cause events, and the patient presented with acute coronary syndrome. in complete trial, the sub-analysis from the complete trial, we found that the obstructive non-culprit lesions are mostly vulnerable. Like with using IVUS, TICFA was detected in 35% of non-culprit obstructive lesion. It means half of patients had an obstructive non-culprit lesion containing vulnerable plaques, and these vulnerable plaques are the plaques which will progress, and we will not pay attention to them. What about the preemptive trials? The Prospect Absorb trials is a trial that enrolled 182 patients, and the inclusion criteria were more than one non-flow limiting non-culprit lesion with a plaque burden more than 65%, and assigned to either absorb by absorbable stent or medical treatment. And this study was not powered to detect the clinical outcome. The primary powered endpoint was the minimal luminal area, and after 25 months, it showed that the minimal luminal area after using the bioabsorbable stent preemptively in treating non-culprit lesion was bigger than the using the medical treatment, and that's shown in the IVUS measurements of the minimal luminal area of after using the bioabsorbable stent compared to the medical treatment. And again, this study was not powered to measure MACE, but here this slide showed that the MACE rate was at 4.3 after using the bioabsorbable stent compared to 10.7 after using the medical treatment only to stabilize the high risk lesion. And why? What is the difference? The difference is that when we use the medical treatment, we stabilize the plaque, but we don't increase the lumen. But if we use a stent, we will add more to the lumen size. There is a couple of studies are going to study the effect of preemptive intervention, the PICTUS and the PREVENT. In PICTUS, we use OCT guidance, and in PREVENT, we use IVUS near and OCT guidance. The aim is to intervention preemptively in high-risk plaques using the bioabsorbable stent compared to medical treatment, and we are waiting for the results of this trials. And this data has been reflected on the guidelines. So the indication of intervention in non-culprit lesion has been progressed from class 3 to 2B to 2A, and this is the most recently published guidelines from the American Heart Association, American College of Cardiology, that give class 1A recommendation to intervention in non-infarct related artery during in STEMI during the hospital stay or when we stage the procedure, and give it a class 2B if in selected cases to do it during the procedure, and class 2A if we need to complete the revascularization after we did the PCI with CABG. So in conclusion, ladies and gentlemen, recent advances in invasive and non-invasive imaging modalities have improved the potential for early and accurate identification of vulnerable coronary plaques. PCI of the minimal luminal area and the ischemia-producing portion of the plaque is clearly inadequate to reduce MACE events in both the stable coronary artery disease and ACS patients. Preliminary data have shown potential for preemptive local treatment of vulnerable coronary plaques with PCI as a complete and Prospect Absorb trial, and this strategy is currently being investigated in other trials. Thank you so much.
Hi everyone. I must thank Dr. Omar Halak for inviting me for this summit to speak on retrograde CTO PCI, a 2022 update. I have no financial disclosure pertaining to this presentation or session. CTO remains one of the most challenging subsets of PCI. The success rate with antegrade approach is around 65 to 70%. Retrograde approach improves the success rate up to 95%. The era of retrograde CTO PCI began with direct two lumen puncture kissing wire, cart, and reverse cart. Reverse cart is the most dominant retrograde technique. Reverse cart has been modified elegantly into several subtypes to improve procedural success and efficiency. So the evolution of CTO-PCI starts with basic antegrade wiring, then follows advanced antegrade IVAS guided wiring, wire-based antegrade dissection and re-entry. It follows rudimentary retrograde techniques such as kissing wire and true lumen puncture, then advanced retrograde with cart, IVAS guided reverse cart came in 2005 when I was in Japan. It was followed by advanced ADR by North American, and finally we put everything together in one basket. So putting it all together, algorithm starts with CT angiography or dual catheter angiography. If the cap is ambiguous, distal target is poor, and there are interventional collaterals, embark on retrograde technique. If the lesion length is less than 20, go for retrograde wire escalation. If it is more than 20, go for retrograde dissection and re-entry, such as reverse cart, cart. If all these techniques fails, we should embark on antegrade dissection and re-entry. As you can see, there are some morphology in CTO where antegrade approach is almost impossible. At least 30% would require retrograde approach. When one should embark on retrograde approach? When the antegrade approach fails or antegrade approach is hopeless, such as flush aortoosteal occlusion, ambiguous proximal cap or stumpless occlusion, CTO with bifurcation at distal cap, CTO with severe proximal tortuosity or calcification, CTO with diffuse disease or poorly visible distal vessel, CTO involving anomalous coronary. This is an article published by me that depicts mastering this technique. So this is the type of retrograde approach, kissing wire and direct wire crossing. Kissing wire involves antegrade navigation of wire into distal true lumen when retrograde wire is kept as a marker. However, the direct crossings, sometimes the retrograde wire directly crosses into proximal true lumen in 30% of the lesion, where the length is less than 20 millimeter. Cart and reverse cart are innovative technology devised by Kato in 2005. Cart involves antegrade navigation of the guide wire into distal true lumen after retrograde ballooning, and reverse cart is retrograde navigation of guide wire into proximal true lumen after antegrade ballooning. This is a RCS CTO. As you can see, the proximal cap is ambiguous. So it was the first retrograde technique done in 2005 in Japan when I was in Toyohashi Heart Center. As you can see, the retrograde wire is going through epicardial channel and to RCA. And that time, the Corsair microcatheter was not there. We had to manage with transit. So the retrograde balloon is inflated for creation of the space for antegrade wire. Then antegrade wire goes into distal true lumen, followed by ballooning and stenting. However, cart has certain pitfalls. Difficulty in negotiating a retrograde balloon inside the occlusion, particularly in complex CTO lesions. Sometimes the subintimal space extends to the proximal true lumen of the CTO, which may cause a fatal event such as left main dissection. And we have to estimate retrograde balloon size empirically, and there is unpredictable procedure time with cart. That's why cart is replaced with reverse cart, and reverse cart becomes the dominant strategy. At least in 60 to 70% of the retrograde technique, reverse cart is adopted, and it is a dominant strategy because it is reproducible, safer, quicker, more effective, and gear handling is easier. This is another paper depicting the types of reverse cart. And as I mentioned, reverse cart has certain subtypes like conventional reverse cart. Reverse cart is assisted by IVAS, stent, mother and child catheter, and transit balloon. Another reverse cut is contemporary reverse cut, which is more popular now, and shifting reverse cut. So conventional reverse cut start with longitudinal overlap of antegrade and retrograde wire. Then balloon is moved towards the antegrade wire. Then you can see antegrade wire is inflated and creation of the subintimal space for retrograde wire, and finally retrograde wire enters into proximal true lumen. This is CTO RCO with grade 2 collaterals from LED, as you can see. So antegrade wire escalation fails here. Then there is retrograde navigation of the wire with the help of microcatheter. So retrograde wire into proximal true lumen after antegrade ballooning. Then microcatheter and retrograde wire both enter into true lumen, and then guiding catheter. Then it is exchanged with RG3 wire. It was followed by antegrade stenting, and this is the final result. So contemporary reverse cut is another revolution in the reverse cut. Here the procedure starts with antegrade preparation. As you can see, antegrade wiring through the CTO, and the balloon is moved towards the antegrade wire. Then retrograde wire comes in. Then antegrade balloon is inflated and creating a subintimal space. Then retrograde wire moves into proximal true lumen. Now the question is why antegrade preparation is required? Because wire control antegradely is easier and safer as compared to retrograde technique. It finds suitable point for penetration of the retrograde wire, a point without dense fibrous tissue and calcification. It decides the antegrade balloon size for reverse cut. We usually don't need a big balloon as in conventional cut. So you can see this is CTO RCA, antegrade preparation started, and antegrade ballooning for reverse cut, and this is the final result. This is an example of contemporary reverse cut. So how conventional reverse cut is different from contemporary? Basic CTO wiring is either antegrade or retrograde in case of conventional, but it is antegrade in case of contemporary. Knuckling of the antegrade and retrograde wire is suitable in conventional, however, it is unsuitable in contemporary. Antegrade balloon size is large in conventional, it is small in contemporary. Retrograde guide wire is low to intermediate penetration force in conventional reverse cut. However, Gaia series are used in case of contemporary. Retrograde wire control is often imprecise in case of conventional reverse cut. It is precise and intentional in case of contemporary reverse cut. The indications of conventional reverse cut are CTO requiring bilateral wiring, calcific and tortuous anatomy. For contemporary, the indications are clear proximal cap, occlusion course without heavy calcification or tortuosity. Unsuitability, none for conventional reverse cut, however, short occlusion, CTO with ambiguous proximal cap, heavy calcification, severe tortuosity, and use of knuckle wires are relatively unsuitable for conventional contemporary reverse cut. Shifting reverse cut is another variety of reverse cut where the position of the reverse cut is shifted. If at one point at the point C it fails here for making a connection, then it is moved towards point F and there is clear cut connection. Now the role of IVAS, as you can see, this is again CTO with proximal ambiguous cap, good collateral, antegrade ballooning for reverse cut, however it fails. Then IVAS is taken into consideration that estimates true balloon size, and we had to use bigger balloon for this, and that follows successful reverse cut with the bigger balloon. So IVAS has a paramount role in reverse cut technique. This is antegrade IVAS. When you use antegrade IVAS, you have to look for few conditions. If the connection between antegrade and retrograde wire is clear, reverse cut with bigger balloon, mother and child reverse cut, stent facilitated reverse cut should be undertaken. If antegrade wire is intimal, then go for reverse cut with balloon sized by IVAS, high penetration force retrograde wire plus bigger antegrade balloon. reverse cut in a new spot, and transient balloon. These are the techniques. One technique fails, then you can opt for another one. If the antegrade wire is subintimal, then we can go for high penetration force retrograde wire plus bigger antegrade balloon. If not, then IVUS assisted retrograde wiring. If it fails, retrograde knuckle plus wire into subintimal space, and then traditional cut. So retrograde recanalization of CQ is quite important. I wrote an editorial. It has several problems. The complications are more, but however, it improves the success rate of CTO PCI. So we should not lock the back door at this point of time. So my conclusion is CTO PCI has revolutionized with the development of retrograde technique. The reverse cut is the dominant retrograde strategy employed currently, as it is easier, predictable, safer, and quicker. The current iteration of the reverse cut, such as conventional, contemporary, assisted, and shifting reverse cut, would further facilitate its adoption with more efficacy and safety. Guide extension catheter and stent may assist the technique. IVUS plays a crucial role. These subtypes warrant further prospective validation. Thank you very much for your kind attention.
Hello, good morning. This is Dr. Ahmed Magdi, in Cairo, National Ambassador of the Sky in Middle East. This is my talk about intervention case scenario. This is the ischemia club, combat MI, Egypt Bifurcation Club, all the activities which we conduct in the Middle East. Why is unusual or high risk patients? Who is the unusual patients referred for angio and PCI? Those with atypical presentation and scenarios, atypical ECG and diagnostic data, elderly, renal, young, and very young, difficult to identify the culprit, ischemia at distance, high risk anatomy, previous MI, cabbage, stents, large thrombi, cardiac shock. Actually, 30% of our elective patients are having high risk categories like that. This is when you have a referred patient with acute infarction and you find more than one culprit artery. This happens is almost 15 to 20% of the patients, like this patient, 48 years old male, smoker, drug addict, acute anterior infarction, but the segment raised also in the inferior leads, and we find in this patient that the LED is totally occluded, and in the same time we found also a vulnerable plaque in the right coronary artery that was also treated because we could not identify which one was the culprit, and both are ulcerated and thrombotic lesions in the same patients. This is the LED where we open the total occlusion, and then we put stent, and then we did the right coronary that is also subtotal occluded. As you see, and this is the right coronary. We also opened and dilated by a stent. This is a 14-year-old boy, smoker, not diabetic, no family history of cardiac disease, presented with acute chest pain for hours, ECG showing inferior infarction. He was started on depth. They thought at first of myocarditis or myopericarditis. However, eventually, coronary was done, and he in the system. Over the right coronary had totally occluded PDA, thrombotic occlusion of a lesion, and this was opened by wiring, and it was stented. We tried to find any cause like familial hypercholesterolemia, something in the blood, something systemic disease, but we found nothing. And so this is a typical example of infarction in a very young, it's 40 years old boy. This is a 55 years old smoker, male. He presented with angina of exertion since 1 year. That progressed in the last 2 months. Function class 2 to 3. ECG was showing non-specific changes. Echo was showing normal LV contractility. Stress ECG was positive. He had chest pain and diffuse segment depression in stage 2. He was advised for coronary angio that was done electively, and it had shown total occlusion of the left anterior descending few millimeters after origin and fills retrogradely from the right coronary artery. And the right coronary was having mid-segment long tight occlusion. The CX was having mild plaques in the proximal segment. There is a ramus intermediate also that was small and diseased. The right coronary artery was large and it was difficult to cannulate. However, it had shown mid-segment 90% occlusion. So the decision for CTO, it's CTO for the LAD, paraosteal, mid-segments, long lesion, and as well as right coronary tight lesion. So we consider a heart team discussion whether recanalization of the CTO or having coronary artery bypass. While waiting, this is the coronary angio, and this is the LAD that is totally included, very proximal from the ostium, and mild lesions in the CX. As you see, and small ramus. And the right coronary artery, that was difficult to cannulate, but it had shown a tight lesion between the proximal and mid-segment, 90%. So, and it gives collaterals to the LAD. So while the patient was waiting for transfer for 10 minutes after the angio, he had sudden cardiac arrests, fine ventricular fibrillation. CPR was started immediately, and he was still very close he was still in the cath lab. So CPR started, some manual chest compression, electric cardioversion several times without any response. Amiodarone was given, bolus and maintenance, adrenaline, bicarb, all the pharmacotherapy for cardiac arrest. And he was already on oxygen. He was already on cardiac massage continuous, intubation, and ambubag. So this shock was performed more than 20 times without a response. Cardiac massage was maintaining the intra-arterial pressure. After 20 minutes, still in the VF, he did not pass into asystole or regaining the regular cardiac rhythm. So what next, what to do? During the massage, we thought maybe there's some dissection that happened during the angio. So we thought of doing coronary angio to exclude dissection, other complications. However, there was no signs of dissection, injury, only sluggish flow. This is a trial to do angio. While the massage was done, it was stopped only for seconds just to see the arteries. And as you see, the ventricular fibrillation waves are obvious from the, even the arteries are moving sluggish, this VF, weak but feeble pulsations. So we continued massage for another 20 minutes, 40 minutes, and then we still he was on the fine VF, not passing into asystole and not regaining the sinus rhythm. So we thought that the right coronary, if we do ballooning for the right coronary, it may improve the coronary flow. Maybe it may give us any hope to revive the patients. But remember that the RCA was having difficult cannulation. However, we passed a wire, we ballooned the artery with balloon 3 by 20 for 10 seconds, and still the patient was in VF. These are pictures of the right coronary artery trying to improve the cleo, but the patient was still in ventricular fibrillation. During the intermittent, this is the picture while trying to dilate the right coronary artery. There was no effect on that. So we thought of dilating the artery by putting a proper size stenting in the right coronary artery. This is after the balloon. So we put a stent 4x18 multi-master with short inflation during stop of the CPR for 15 seconds. And you can see the series of angio before and after. That is the guiding cath in the right coronary artery. And this is a wire. It's coming up. And as you see, there is no movements of the heart at all. This is a wire and this is a stent. This is live movie. And this stent opens. And he is only having the ambu ventilation. And then we continued massage after that. And this is the picture. This is the artery after stenting. Sludge flow. There's no movements. So we continued massage. However, we found there is a sudden response, and the coronaries were filling again, and the heart resumed its activity. That is after stenting of the right coronary, and then suddenly the heart started to beat again, and the left system was the same as it was before. So e-tropes were continued for a few hours. He suddenly regained his consciousness after 4 hours, got some broken ribs. He was discharged after 4 days, and this was an astonishing case of doing intervention while the patient was stand still for almost 80 minutes. It was very surprising, and we were happy for success of the intervention and good resuscitation. Thank you very much.
Wow. That was a great way to end that session.
Excellent cases.
Very nicely done. So Dr. Reddy and Dr. Dash, such great presentations. And I actually have some questions for you all. And if we have questions from the audience team, please let us know about that. But I think, Dr. Reddy, you were talking about, the OCT, right? And looking at vulnerable plaques. So I think the audience would really like to know, when we have this non-obstructive disease that Dr. Dia was talking about also, how aggressive should we be when we see these things? They're non-obstructive. So we get a lot of cardiac cath that say non-obstructive disease, medical therapy, right? And they let them go. And we know that these patients are having this vulnerable plaque and they're such high risk. How aggressive should we be? Yesterday I asked the question about drug-eluting balloon and should we be doing something else, maybe lining the artery with something? We're not there yet, but what do you all think about that?
So the first thing is when you have, it all depends upon the situation. If you have an acute coronary syndrome like a non-STEMI with a troponin elevation, these patients, when they come to the cath lab and you see 40%, 50% lesion and you're not sure, rather than just writing it off as non-obstructive coronary disease and not telling what exactly is the culprit vessel, there are times when I do OCT to find that vulnerable plaque, the ruptured plaque, and all those things. So that's number one is, if you are suspecting a acute coronary syndrome at the higher range, non-STEMI especially, you want to make sure that this non-obstructive disease is not something more than a vulnerable plaque. It has had a rupture or something like that. So that's one area where I use OCT to determine. Also, like Dr. Magdi's presentation, sometimes you have 3-vessel disease in a non-STEMI and you don't know what's the culprit because the EKG looks fine. And you brought the patient to the lab because of elevated troponins and ongoing pain. So you don't know which is the culprit. So those are the places. Now, let's say you bring them with an abnormal stress test and you see a disease in an artery not related to that area of ischemia in the stress testing. and you have an inferior ischemia, and you have an LAD which has got 60%. Now, that's the ones where we need to see this for sure. They have a plaque. Do we need to go in and evaluate it further to see if this is vulnerable? The point is, let's say it is vulnerable. The treatment right now may be changing, as we may go ahead and do preemptive stenting, but otherwise we are still in the phase where we just give high dose statins to regress the plaque. So I think imaging is very important in assessing vulnerability. Like Dr. Hakim said, several things, IVUS, the OCT, the nurse, and spectroscopies and all those things. But I think medical management will be aggressive in this non-obstructive disease. And if you're leaning more towards an higher range acute coronary syndromes, you may even do this preemptive stenting.
Exactly. So what do you all think about this? You know, there's such an underlying risk, right, that we're not looking at, the residual risk that I talk about when I give lectures, you know, around the world about what else can we be doing? Why are we still having coronary artery disease, the #1 killer of men and women in the whole world, right? So what? How aggressive should we be on that? What else would you all suggest, or do you talk about those things? I do something called the pulse cardiac test, which I talked about in my lecture. It's a blood test that looks at other inflammatory markers that have been evaluated, even with Cleveland Clinic, showing these are high-risk patients to have an MI or a stroke within the next 5 years. So should we be looking more at that and not so much at the final obstructive lesion?
Let's get Dr. Dash give us some excellent comments on this with his huge experience.
Yes.
What do you say? What do you ask? Actually, I didn't get you.
Well, I'm saying with all these inflammatory mediators that we can be looking at now, should we be more aggressive in treating inflammation in these vessels when we see non-obstructive disease, or when people don't have OCT to look at?
Yeah, but then we don't have enough data to suggest that you need to treat inflammation, right? Even plaque sealing in vulnerable plaque is also controversial at this point of time. I think this came up maybe many years ago, and again it is revisiting. Still, we need more data to justify the treatment.
So we should be doing more clinical trials on this one thing.
Exactly.
So that
medical therapy will play a role. It will continue to play a role in these type of cases until and unless we have more data.
I'm a champion for anti-inflammation.
Yeah, so you can shed some light. I mean, what you have been doing so far. Yes. I mean, are you treating inflammation, and then how it is?
Yes, I'm actually able to stabilize coronary vessels using the pulse cardiac testing and treating different areas of inflammation with even non-prescription mechanisms. You know, I'm looking at areas of glutathione use and high-dose vitamin C and things that Linus Pauling talked about a long time ago, right? So even though, we train at Texas Heart Institute, we have all the stents in the world, but sometimes we have to look at the inflammatory procedure, what's happening, in the vessels. And that's what I like everybody to take home from even this great interventional conference, right? To know that we can be stenting and doing procedures, but let's look at the deep cause of what's happening in those vessels, right? Whether it's the coronaries, whether it's the brain. I love that case that Dr. Magdi talked about, and he's not here, but I think you all can talk about this. That 14-year-old boy, I don't know what time frame that was when he came in. Was it recently in the setting of COVID? Was he having a cytokine storm causing that thrombus formation? He wasn't able to talk about that, but I do believe, and I've asked this question to many of the moderators and speakers, do you think that we'll be seeing multivessel thrombus formation in this post-COVID period? And beyond the long hauler syndrome that I talked about, really sets the stage for that.
We have seen some, thrombotic situation post-COVID, actually thrombus in 2-3 arteries, and managed medically. When the angina subsided, we didn't do anything. apart from giving some what do you call eptifibatide and then putting the patient on oral anticoagulant. But then again, it doesn't have data. It is our experience putting them on oral anticoagulation for 1 month and then take them for angio and see what happened. And surprisingly, thrombus disappeared from most of the arteries and no residual was there.
Yeah, this, and we don't know, this is uncharted territory, right, Dr. Reddy?
It's a completely uncharted. We have seen such an amount of hypercoagulability in terms of coronary artery thrombosis and also PE. We also have an active PERT team, and we are called for a lot of PEs to be taken care of. So yeah, exactly. And Dr. Dash is absolutely right. There are times when we do not do anything. We do the angiogram. We see 2 vessel thrombosis with TIMI1 or TIMI2 flow in the other vessels. We actually stop. We give them 2B3A inhibitors, and we just treat it. I mean, even in a setting of a ST elevation in like an inferior or something, we don't want to just go and sometimes we may just go ahead and balloon it, open it up, and not stent it, because this is a thrombus. You just want to macerate, mash the thrombus, and just make sure it just washes away. And yes, this is a completely uncharted territory where suddenly the hypercoagulability nature in the body affecting the acute coronary syndromes. But
Right.
coming back to your point, Dr. Verghese, I know you have done a lot of these things. I do have a lot of patients who come and say that IV vitamin C infusions. I do this. And remember, we went from antibiotics. Remember, we were given Zithromax for so many of them before at one time. Anti-inflammation, right? Anti-inflammation. How do we target anti-inflammation with so many things? Colchicine, IV high-dose vitamins, vitamin Ds, and all those things. For sure, we all agree one thing for sure. Prevention is much better than what it is, right? And we want to prevent that. And if we can prevent that, that is the role of medicine over there. When they come into the cath lab, that's a different thing. We are all interventionists. We do what we love to do, but not bringing them to the cath lab is more important than what you bring to the cath lab and you do it. I think
That's
for
right.
sure. I think that's where the whole science has to go. It's like that small.
I agree with you, Dr. Reddy. Yeah, exactly. The more experience we have, we come to a conclusion that this prevention is better than cure.
Yeah.
But when it comes to treat it, we have to.
Yes, we have to do our best. Yeah, exactly. Like Dr. Magdi's case. Once they come into the lab, it doesn't matter. It's 60 minutes, 80 minutes. You just give your best shot, and things can change.
And I think that we'll never run out of people coming to the cath lab, because the world is full of coronary disease, peripheral vascular disease. So much so, I do think that in my own practice, I've been able to see when I do the pulse inflammatory test, the blood test, I can lower that by 50% with the medical regimen and the anti-inflammation that I've been doing. And I've been doing it now for, I don't know, 10, 15 years. So I don't want to, say that that's the only way, but that is a definite benefit to look at inflammation. So I think we are heading towards our next session. Do you all have any other comments on any of the lectures that that we heard today? Anything else you'd like to?
Just a comment, Dr. Dash, your lecture was awesome. I mean, you have so much experience. In fact, just before, it's about 8:55 for me in the morning here in Dayton, Ohio. And I woke up at 6 o'clock and I was looking at the latest JAC from January. There's a whole CTO review article with all the global things and all. And I mean, it was like, I read that in the morning and you told me what to do, kind of. And I've been doing CTOs for the last 10 years. So it's a pleasure to be on the same podium or stage or virtual with you, sir. Thank you.
Thank you very much. Thank you. I think I'll be coming to CRT. If you are there, we can.
Yes, I've been to Bill Lombardi's place several times. I was lucky to be in his lab and help and all those things. Very nice.
Thank you very much. Thank you for your comments and enjoy. Thanks, Dr. Eli.
Thanks, Dr. Verghese.
You all are so wonderful. It's such an honor to be moderating this great conference.
And for sure, 40 years, it's an awesome conference. Dr. Halak, thank you for having us. Hopefully next year, we will be in Dubai, all of us.
Yes, we will.
That's what it is.
And I want to put a shout out to people to join the International Society of Endovascular Specialists. So Dr. Frazier and Dr. Halak are the leaders in that with regard to the U.S. and the UAE. So everyone, when you're coming to these conferences, really become a member of these great groups where you can learn all the time. I've been in practice over 20 years, and I learn every day from the masters, and so thankful to be taught by the great giants at Texas Heart Institute.
Thank you.
Thank you.
Thank you.
Now, we're going to start our next session. I think I'm waiting for some of these other moderators to come in, and we will be talking about the understanding management of hypertension, dyslipidemia, how to intervene in chronic ischemia syndrome, MI with normal coronaries, oral semaglutide, and COVID in the heart. So lots of great speakers coming up. Welcome. Dr. Nushin, Dr. Manoria, Dr. Leila. Looks like people are joining in. Welcome. This is our last day, but we have chock full of information. Can everybody hear?
Yes.
Yes, I think Leila, yes.
Hello, everyone.
There you go. Hello.
Hi, Dr. Rani.
Hey, welcome.
How are you?
Very good. Dr. Manori, I think you're on mute, sir. Very good. I think just unmute. Welcome.
Good evening.
Good evening. We are starting this next session, and as I said, we have some great topics. We're going to start Dr. Samar Alaham in UAE, and then Dr. Majdi from Egypt. Let's see, Dr. Leila is going to speak, right? And Dr. Minoria, and then ending up with Osama Halak, Dr. Osama Halak. So welcome, and thank you, team. Let's get started.
Thank you.
Hello, and thank you for joining me on my humble presentation looking at a paper that I published with my colleague Dr. Wael and Dr. Lina from the United Arab Emirates and our colleagues from Dubai. The paper is really looking at understanding the management of hypertension and dyslipidemia, not a new topic, but I think what's a little bit relevant here and new is in UAE population. It's an evidence-based mapping of the literature. My name is Samar Alaham. I'm from Cleveland Clinic, Abu Dhabi, and I'm very glad to join you. So I think the interest here is that we have limited data from GCC. We do have data, but they are somewhat limited on hypertension, dyslipidemia, and chronic disease management. And I think the fact that we made a humble effort with our colleagues to look at the UAE population with evidence-based mapping of the literature may be of interest to all of us in the conference. And again, I want to congratulate Dr. Omar Halak and the team for an outstanding conference, the organizing committee. Thank them for inviting me, and I'm honored to be a humble speaker among this amazing group. So this is an original paper entitled, like the title of my presentation, Understanding the Management of Hypertension, Dyslipidemia in UAE Population in Evidence-Based Mapping of the Literature. And I will be going over it briefly, and I hope you'll find the findings interesting. So I want to thank Cleveland Clinic and Cleveland Clinic Abu Dhabi for allowing me to do this work. Again, dyslipidemia, hypertension, we as cardiologists still see those with all other concerns that we have, including lifestyle issues, smoking, diabetes, etc. And, we wonder what are the data in UAE. We have an impression before we really looked at the data from the paper that it's very prevalent, that it occurs at a younger age, and that it seems to have significant impact on the cardiovascular system. So I want to thank Dr. Wa'il Mahamid, who needs no introduction, my brother and colleague and friend, Dr. Lina Yassin from Imperial College of London, and Dr. Canwell from Dubai for their support and assistance in writing this paper. Again, I think these colleagues need no introduction. The agenda is just a brief introduction first. I think all of us are aware that the number of deaths worldwide attributed to non-chronic disease illness, now we're talking about non-communicable diseases, and now we talk about it as something a little bit unusual because we have the communicable disease of COVID-19, but it increased by a staggering 18.5% from 2010 to 2019. So within less than 10 years, we have almost a 20% increase, 18.5%, and that is globally. And when we look at our area and when we look at where we are, we're talking about similar number, not really less. And the number of deaths is remarkable, almost 17% increase. And we're talking about almost 19 million deaths. So I don't think we need to reinforce this. You, I'm sure, know it. If you don't remember the percentages, I'm sure you know that it's a very big deal. And I hope you agree with me that this is a concern. In the Eastern Mediterranean region, around 55% of non-communicable deaths were due to cardiovascular death. So more than half of the non-communicable deaths are related to the cardiovascular system. Are you surprised? No, but I think we should share this with our colleagues and our patients. The reported cardiovascular risk prevalence in a multinational cross-sectional Africa, Middle East cardiovascular epidemiology study, the ACE study, in a young population where the mean age is around 45 years, 46 years, so very young, attending outpatient general practice clinics, dyslipidemia is 70%, hypertension almost 45%. In the United Arab Emirates, our beloved country where we all live and work and practice, cardiovascular diseases contributed to around 37% of all deaths in 2017. A high prevalence of dyslipidemia, around 75%, even higher than global, and hypertension was noted in the young population aged 45.1 years. So quite a remarkable concern. Not only the prevalence is high, but at a younger age. And that's something that's very concerning. The Ministry of Health had several interventions, and some of us were part of these interventions, and we thank the Ministry of Health for working on all the Emirates to address, such as tight control, MOHAP, non-communicable disease action plan, primary prevention, and the plan really focuses on strategic areas, non-communicable disease governance, prevention and awareness, etc. I invite you to review it, please, because I think it adds a huge value. Our attempt was to have a semi-systematic review to quantify the different phases of management. We thought about it as several phases: awareness, screening, diagnosis, treatment, adherence, and control. So 6 phases of management of hypertension and dyslipidemia in UAE. The method, I'm not going to really spend too much time with the method, it will take too much time, but very briefly, we had 2 research questions: the evidence regarding management of hypertension, dyslipidemia in UAE, and areas of management need more attention for better care. And we addressed this using these 6 areas that I discussed with you, and I invite you to review the paper for further details. The results very quickly, because I have very limited time. The results, after we did a flow chart of the literature, included the appropriate studies for hypertension, and that is the method beyond the scope of today's very brief presentation. And dyslipidemia, again, the method will take quite a bit of time to explain. This is what we were able to find. So we have the 2 areas here. You have the hypertension, and you have the dyslipidemia. So hypertension is in pink, red, and dyslipidemia is in yellow. So you can see the prevalence, the awareness, the screening, the diagnosis, the treatment, the adherence, and the control. So obviously, very concerning, very concerning. So obviously, in these studies, we were able to find 11 studies on hypertension and 6 studies on dyslipidemia considered to be relevant. And these were some of our recommendations, and I will end very briefly, quickly. Awareness, screening, diagnosis, treatment, and adherence. And we discussed in the awareness, the depth discussion of the cardiovascular risk, dissemination of the risk factor through patient brochures, facilitate community education. Then we went in screening the primary care physician and their important role. And again, I cannot go over this in detail because of the limitation of time. Treatment to urge individuals at risk of hypertension to visit healthcare facilities and clinicians to really consider patient-related factors. Adherence, to improve adherence through treatments, simplification, and many other things that you will find very interesting because they come from evidence-based literature. So I really invite you to look at this paper, and we hope that this humble effect of the group that I work with and my humble self adds some value and save life in our beloved UAE. And this is again the same content that I discussed with you. Summary of the recommendation for government and policy makers. Again, time does not permit me to go over this, but we went specifically over evidence-based recommendations to address this very important topic. Unfortunately, I cannot give justice to the paper because of the very limited time allocated to me. Limitation is obviously, this is a semi-systematic review that has some limitations. The most important is that the data on different phases of management of hypertension were not consistently available in all articles. So the pooling of the data was a little bit of a challenge. Conclusion, and I will end now, so I'm not told that I took too much time, is this is the first and humble, comprehensive, evidence-based mapping of the literature on different phases of management of hypertension and dyslipidemia in the United Arab Emirates population. Although we performed a comprehensive review to gather locally relevant data, the number of studies discussing patient-centric outcomes for the management of hypertension, dyslipidemia, as you know and as you expect, is limited. So we encourage all of us, including the speaker, to conduct more local research to address our important local issues. Addressing data gaps at different stages of patient management would need a multidisciplinary effort at the national and healthcare level and population level. This study may provide a basis for research priority settings and guidance to practice and amend health policies in the contents of the United Arab Emirates. I want to acknowledge and thank my colleagues, the researchers, and namely, I mentioned their name already. And I want to thank and recognize Reactress, who provided an unrestricted support for this publication. Thank you very much and have a great day. Please look at the article, communicate with us, and let's collaborate to do more and better research in UAE. Thank you for TS. Have a great day.
Hello, good morning. This is Dr. Ahmed Magdi, consultant cardiologist from the Heart Institute in Cairo and the national ambassador for the Sky Middle East. My subject today is how and when to revascularize patients with chronic coronary syndromes. There are some goals for therapy in patients with coronary disease in general to improve the quality of life, reduce mortality, reduce morbidity, reduce the progression of the disease, and induce some sort of regression and in a costly manner. Why could revascularization of ischemic arteries be important for better tolerance of the events in other coronary distribution, altered urology within the index vessel, less progression or decreased ventricular function, ischemic cardiomyopathy, and less occlusion in the index sites? There are so many multiple studies that have shown a powerful relationship between the severity of ischemia and survival over the years. The more severe ischemia, there is the survival as the natural history. So what do you prefer if there is a proximal tight lesion in one of the major coronary arteries, to get a coated stent or to have only medical treatments? This is important. The guidelines of coronary syndromes that had been announced in 2019, they had already declared 6 subgroups of coronary syndromes, including those with suspected coronary disease or new onset symptoms of angina, dyspnea, patients with new heart failure, patients stabilized with 1 year of acute coronary syndrome or after intervention, or after 1 year from revascularization, patients with vasospastic angina, and those who are accidentally discovered to have coronary artery disease. There are so many ways to investigate and pass through to make the strategy for treatment and manage with such patients, but it depends on the likelihood of having coronary disease. If this likelihood is low and you need to investigate, then coronary CT may be the ideal. While if there is high likelihood of having severe coronary disease, then invasive strategies may be utilized, especially in the presence of physiology testing inside the cath lab. In between this and that, maybe the imaging modalities and the assessment of the degree of ischemia are helpful. We should consider the symptoms, the revascularization futile, the ejection fraction and left ventricular function, the cause of chest pain other than coronary artery disease. And this important slide is showing that if there is, for what to do with the patients with angina or dyspnea and suspected coronary artery disease is the main diagnostic pathways. If there is low likelihood to have coronary disease and you have a good imaging facilities and good expertise, coronary CT may be used. And if the patient is having high likelihood of in the form of severe symptoms refractory to medical therapy, typical angina at low workload, or elevated function suggestive of coronary artery disease, then invasive strategy by coronary angio may be required. Patients in between who are having, for example, CT, but the lesions are borderline, maybe non-invasive testing for ischemia are helpful. While if you are doing the coronary angio, after if the CT is proved the significant coronary lesions, or if there is other ways that lead you eventually to have invasive coronary angio, and then if they have a tight lesion, then you will go for revascularization. If the lesion is not tight, intermediate lesions may need functional assessment inside the cath lab, and otherwise, if the lesions are mild to moderate, maybe drug therapy may be required. So if the patient is presenting with coronary syndromes, if there is significant symptoms and there is documented ischemia, and this ischemia the patient turns out to have multivessel disease, then depending on the results of the coronary angio and the physiological testing, revascularization may be performed. If there is no documented ischemia, but you have a severe lesion, 90% proximal, or FFR is low, or ejection fraction is impaired, then still revascularization may be required. While if the patient is asymptomatic, if he is having little symptoms, and you demonstrate severe ischemia, then the same that applies for ischemia in the presence of symptoms will apply if there is silent ischemia. Then revascularization will be required if there is large area of ischemia, over than 10% of the LV, or if there is severe lesion over 90% proximal, or FFR is compromised, ejection fraction is compromised. So in order to have intervention and revascularization, you need to be justified by having important effect on the prognosis and the outcome of the patients, and to relieve symptoms. Mind you that at least 1 million of PCI are performed every year in the USA. Most of them are for acute coronary syndrome and MI. Prior studies had shown that PCI only decreases the frequency of angina and improves exercise performance, What we know that PCI is not perfect. It treats only the treated area. It has potential for stent thrombosis and restenosis, which will, while uncommon, still symptoms may still occur. We remember the COURAGE study in 2006, 2007. The medical therapy compared to the invasive strategy revascularization among patients with chronic stable angina. They found no difference in the primary outcome and the secondary outcome. The conclusion was showing that PCI may reduce angina and improve the functional status during most follow-up in the patients. However, there is a large preponderance of procedure MI and death spontaneous MI, actually less after PCI, and 30% of the automatic treatment patients, they shifted to invasive strategy. On the other hand, in the sub-study, the Thalium sub-study had shown that the mortality rates progressively increased in the medically treated patients if there is severe ischemia, while those with low ischemic burden, the mortality was the same comparing invasive strategy and medical treatments. The latest study, ischemia study, international study of comparative health effectiveness with medical and invasive approaches, ischemia. They compared patients with moderate or severe ischemia. One arm was invasive strategy, optimal therapy plus intervention, optimal revascularization, while the other side was only conservative treatments, no intervention. And they found no difference in the primary outcome and in the secondary outcome between the two arms. And the conclusion was that ischemia, which is the largest study of the invasive versus conservative strategy, the initial invasive strategy as compared to initial conservative strategy did not demonstrate reduced risk over 3.3 years of follow-up in the primary outcome and the secondary outcome endpoints. However, we need to consider many facts. That there are some goals of therapy patients stable coronary disease to improve symptoms, quality of life, and to improve the prognosis. Is one thing. For the revascularization to be performed, it should be done safely with high quality and durability to minimize short-term and long-term risk. And also, it should be performed on the lesions causing symptoms or reducing ischemia. There is some facts also that symptom relief is one thing. However, don't forget about the history, the workload, exercise tolerance, progression of the disease. Revascularization efficacy depends on the degree of ischemia at the baseline. This has been shown in most of the studies. There is a wide range of morbidity and mortality among patients with stable coronary disease, depending on the amount of resting ischemia. The confirmed study and several other studies had shown that the higher the severity of ischemia, the less the worse the mortality and the less the outcome. If we optimize our intervention by having the IFR or FFR, like in the FAM study, then we can demonstrate patients who will benefit from intervention with chronic coronary syndromes if we depend on the results of functional testing. That there is that we do intervention in lesions and in the arteries where there is ischemia below 0.8. This had been proved in the FAM1 and FAM2. There are some other facts also that there is some adverse outcome related to underutilization of coronary angio. If patients are in need, but we don't do that, then there is some, the outcome is compromised. We know that some of the procedures are considered inappropriate, others are appropriate, and in between they are considered uncertain. Don't forget also the patient's opinion about treatment, because many patients are not adherents, they don't like the treatments, especially if there is polypharmacy. This should be considered in patients, if they are tolerant or not. Among patients referred to big cardiac centers all over the world, there are some appropriate and uncertain and inappropriate, but if we consider that intervention is done in patients with appropriate procedures, then the outcome would be better if we do the invasive strategy and intervention. the potential downsides of appropriately performed revascularization that you consider the social issues, decreasing revascularization costs. However, the patient risk is more important to take care of that. What happens in reality? There is variability in practice among patients referred for intervention or for CABG. Most of the patients who are referred for revascularization nowadays are done by intervention cardiac catheterization. The conclusion is that which patients we prefer to do optimal medical therapy, those with mild symptoms, exercise capacity is normal, ischemia is mild, anti-angiogenic treatment tolerance is good, patient PCI risk is high, and there is some poor tolerance for the that. While patients where we prefer PCI are those with severe ischemia, reduced exercise tolerance, moderate to severe ischemia, poor anti-angiogenic treatment tolerance, low and that compliance is good, patient risk is low. So in conclusion, coronary atherosclerosis is diffuse disease. Optimal medical therapy is the foundation for all patients. Patients preferred for intervention are those with STEMI and those with non-STEMI, while stable ischemic heart disease patients, whether CABG, PCI, or initial optimal therapy are chosen. All must be individualized according to the patient condition, clinical and anatomic consideration, and operator expertise. Thank you very much.
Assalamu alaikum. Good evening, Chairman. Good evening, ladies and gentlemen. Thank you for giving me this opportunity to present a very interesting topic, which is unfortunately not known to a lot of people, which is myocardial infarction with normal coronary arteries. This condition has been known for over 75 years. And as I said, not a lot of people know about it. That is when a patient has acute myocardial infarction with normal coronary arteries, but lately the name has changed to a myocardial infarction with non-obstructive coronary arteries, which I'm going to refer to it for the rest of my presentation as MINOCA. The definition of this condition is somebody would come with acute myocardial infarction, and by what I mean by acute myocardial infarction is based on fourth universal definition of MI criteria, which they have ischemic symptoms and the ECG changes or the echocardiography changes with elevated troponin, but they have on angiography, they have non-obstructive coronary arteries. That includes either normal coronary arteries or mild luminal irregularities, that I mean less than 30% stenosis, or moderate coronary atherosclerotic lesion, which is 30% to 50% lesion. And in doing so, one in the clinical presentation must exclude non-specific alternative diagnosis for the clinical presentation of chest pain and elevated troponin, which could be pulmonary embolism, myocarditis, or sepsis. The epidemiology of the MINOCA is interesting because it's not an uncommon condition. It occurs in 6 to 8% of a population, and in some population occur in 15%, depending on the population which are diagnosed with acute myocardial infarction. And the estimated incidence of this condition in the US is around 50 to 100,000 cases per US population per year. And it is more common in younger patient, Black, Hispanic ethnicity background. And it is commoner, of course, in women than in men, twice as women get the MINOCA compared to men, and up to 50% of MI in men and women, there are MINOCA cases, and most commonly non-ST elevation compared to ST elevation patient, and event may include type 1 and type 2 MI. If we look closer at the epidemiology of MINOCA in other different studies and registries, so they have found different incidences in different study and data and mean age, but overall that we can see, for example, in Virgo study, they found the 90% in women, it is present, but they found that the age varies in different studies and in different registry. Interesting enough, one of the conventional risk factor among patients with MINOCA, they found an Action GWTG registry that the conventional risk factors is not necessarily present in this patient, and except for the hypertension that was found 65%, but majority of the patient, they were not diabetic and not having any conventional risk factor. So the current focus is to discuss the misconception by some clinician who still think that if somebody does not have the absence of non-obstructive coronary artery disease, that will exclude the possibility of myocardial infarction. So what is the etiology of MINOCA? So it varies. It could be plaque rupture or erosion, or it could be thrombosis, or it could be the coronary artery dissection, or supply and demand mismatch, or epicardial coronary vasospasm, or microvascular dysfunction. And on the right of the screen, you can find the plaque erosion and rupture, and you can find that on this picture that we have on the right side of the screen. This is a case scenario, 53-year-old woman with hypertension, hyperlipidemia, presented with 30 minutes exertional chest pain, which went to her left arm and jaw, and she had mild dyspnea and episode of nausea. She came to casualty, and troponin was high, but the ECG was normal. However, the echocardiogram showed hypokinesia of the basal interventricular septum. And based on the clinical presentation, a diagnosis of acute myocardial infarction was made, and she was referred we take her to for angiography, and the diagnosis of myocardial infarction with non-obstructive coronary artery was established. So this is the coronary angiogram of the left and the right system, and as you can see that it is normal. So the question which arises now here, how would you diagnose MINOCA? So a patient comes with symptoms, and which is classical of acute myocardial infarction, and then their coronary angiogram is normal. So where do you go next from here? So this is kind of like a traffic light algorithm that leads you through sequences of diagnosis of MINOCA, and it is 3 steps. So first step is when you have to stop and think. If you find the patient who has presenting clinically with sign and symptom of ischemia, and then what clinical diagnosis would you consider? So if it's non-obstructive coronary artery angiography, so what would you say? So you have to think about alternative diagnosis. Is it pulmonary embolism? Is it sepsis? Then if it is not, and you've excluded these things, so you have to go in through working diagnosis to go back, for example, to your coronary angiography and see is there any missed obstruction, or if there is non-ischemic mechanism to the myocardial injury. And so we might need just to think these diagnoses, differential diagnoses into the account. Is there coronary embolism, or is there dissection or myocarditis or Takotsubo syndrome? And then if all of these are excluded, then you go and do the diagnosis of MINOCA. The reason is you do that is because the etiology of the disease would make the treatment plan more appropriate. So if you establish the diagnosis of Manuka, so what it would be next then? The next it will be coronary vascular imaging and functional assessment through IVIS or OCT, and then cardiac MRI to confirm the specific diagnosis that you have in mind. The Sweetheart Registry, it shows that it is an observational study that we got a lot of information about once Manuka is confirmed. So what is next? So what treatment would you give? So this registry has given us kind of like shed light on what treatment we should use. So they followed 136 patients for 4.1 years follow-up, and they confirmed the benefit of long-term effect of the use of statin and the other the conventional medication that we use for myocardial infarction with coronary artery disease. So they found that there's significantly lowering event rate in using statin, ACE, or ARB in patients with Manuka, but lesser extent with beta blocker and no association of lowering event with dual antiplatelet therapy. So unfortunately, we don't have a randomized controlled trial on what is the best treatment for Manuka. There is Manuka BAT trial that is at the moment is going on and evaluating the best treatment in these patients. That's due to finish in 2026. And this is Kaplan-Meier curve, survivor-free of MACE in patient with Manuka with medication, and confirm what we have already discussed before. The secondary prevention, again, this is a graph comparing Manuka to myocardial infarction with coronary artery, with patients who have got coronary artery disease and different treatment therapy. So the prognosis in patient with Manuka, different studies is found differently, but definitely all they come into consensus that is not a benign condition. So reinfarction after Manuka, the Sweetheart Registry again looked into that and found that 340 patients underwent repeated angiography, and 47% had myocardial infarction with coronary artery disease with the second event, and there was no differences in terms of mortality at 38 months between recurrent Manuka or patient with myocardial infarction with coronary artery disease. And then in hospital and long-term mortality after Manuka, we have the Action Registry, and we have the Sweetheart, and the meta-analysis. They found overall that there's 2.2% annual mortality after Manuka compared to the general population of the same age and sex. And the adverse major cardiovascular event over long-term follow-up after Manuka, comparing Sweetheart Registry with CathPCA Registry, and this is the predictive of adverse outcome in terms of death throughout to MACE in coming 1-year event rate and 4-year event rate. So in conclusion, it's not an uncommon condition, and a large proportion of women with acute myocardial infarction have Manuka compared to men, and the traffic light algorithm is very important for diagnosis and guide us through treatment of the condition. The observation study suggested the benefit of statin, ACE or ARB, and beta blocker, but lesser extent the antiplatelets therapy. And as we mentioned, prognosis is not benign, and more randomized controlled trials of secondary prevention after Minuca are urgently needed for better management of patient with this condition. I hope that these slides were somehow beneficial, and you will put this condition in mind in treating your patient in clinical setting. Thank you very much.
I would like to thank Dr. Omar Halak for inviting me to this wonderful 40s conference. For the next 8 to 10 minutes, I'll be talking on oral semaglutide, innovation of the century. GLP-1 receptor agonists were previously available in an injectable form, although they produce good glycemic control, minimal or no hypoglycemia, decreases weight, decreases ASCVD, and they have been recommended by all guidelines across the globe for treatment of type 2 diabetes with ASCVD or at high risk of it. But their availability in an injectable form has precluded their widespread use across the globe, and only less than 10% eligible patients are on injectable semaglutide. So several attempts have been made for several years to produce an oral formulation, but they failed repeatedly. And this was considered to be a daunting and a near impossible task because of panoply of reasons. Because when oral semaglutide is given orally, it undergoes degradation in the stomach due to low pH and proteolytic enzyme. It has a limited permeability across the gastrointestinal epithelium, and the bioavailability is very low, less than 0.01%. So it produces only limited absorption. But all of us know medicine is essentially a resolution of uncertainty, and this has time and again been proved on several occasions. And after repeated experimentations, success was achieved by co-formulating semaglutide with absorption enhancer SNAC. So when this co-formulation is done, the absorption enhancer SNAC causes a local increase in pH, protecting it from proteolytic enzymes, and increases solubility. It promotes semaglutide absorption across the gastric epithelium and increases the bioavailability of oral semaglutide. And this is the this is semaglutide, which is co-formulated with absorption enhancer SNAC 300 milligram. So when this oral semaglutide is taken in the stomach, as you can see, it is absorbed transcellularly, and even after a single dose of 10 milligram, sufficient levels are reached, and this is persisting for 24 hours. So if somebody misses a dose, it can be taken the next day. This shows the exposure-response relationship, and you can see whether you take semaglutide orally or subcutaneously, the levels are exactly same. So oral semaglutide is now available in a pill with efficacy and safety of injectable semaglutide. Oral semaglutide is the first ever peptide available in a pill across the world and is the innovation of the century. Already launched in 5 countries across the globe, and in India it has been launched in mid-January 2022. It has been tried in nearly 10,000 patients, and the Pioneer Phase 3A is the clinical program. It has been tried in Pioneer 1 against placebo, Pioneer 2 against SGLT2 inhibitor AMPA, Pioneer 3 against DPP4 sitagliptin, Pioneer 4 against GLP-1 receptor agonist liraglutide, Pioneer 5 is renal impairment, Pioneer 6 is the CV safety trial, Pioneer 7 is flexible dose adjustment versus DPP4 with extension, Pioneer 8 is an add-on therapy to insulin, and Pioneer 9 and 10 are the Japanese trial versus liraglutide and dulaglutide, and the sole trial superiority trial is ongoing. So what is the glycemic efficacy of oral semaglutide? This shows that oral semaglutide results in reduction of HbA1c to the tune of 1.5%, which is better than most of the oral anti-diabetic medication. 7 out of 10 patients achieve the goal of HbA1c less than 7%, and if the baseline HbA1c is more than 9, the reduction in HbA1c is to the tune of 2.6%. Asians have a better glycemic response to oral semaglutide, as you can see on the slide. The beauty of oral semaglutide is that it provides a disease-modifying approach by targeting 6 of the 8 components of venous octave and helps in blunting the progress of the disease. And this is achieved without any hypoglycemia. It also decreases weight by 5 kgs. And when we look at the combo of reduction in HbA1c and weight, larger number of patients achieve this combo goal. And a 5% reduction in weight, you can see, produces marked improvement in a panoply of cardiometabolic parameters. And when we look at the reduction in HbA1c, as you can see on the left, or the reduction in body weight, as you can see on the right, they are identical with oral versus injectable semaglutide. This is the CV safety trial of oral semaglutide, the Pioneer 6. It achieves this goal of non-inferiority, and the reduction in primary endpoint of cardiovascular death, MI and stroke, was to the tune of 21%. Cardiovascular mortality was reduced by 51%, and all-cause mortality by 49%. And this is the pooled analysis of the cardiovascular outcome data of SUSTAIN 6 and Pioneer 6. You can see a 24% reduction in the primary endpoint, cardiovascular death, MI, and stroke. And this is the SOUL trial, which is the superiority trial, which is ongoing, and the duration of this trial is 5 years. So what are the dosing instructions? This has to be taken on an empty stomach with half a glass of water, nothing to be taken for the next 30 minutes, and then the patient can have this breakfast. The first dose is started with 3 milligram daily for 1 month, then it is escalated to 7 milligram for the next month, and after another one, 14 milligram. This is the maximum dose. And this, you can see the side effects of oral semaglutide are exactly the same to injectable semaglutide. To the left, the nausea, and to the right is vomiting. They are entirely same. So oral semaglutide is very useful in patients who have an established cardiovascular disease or at high risk of it, patients in whom hypoglycemia is a concern, patients of diabetes with obesity, patients who are not able to achieve adequate glycemic control with 1 or 2 anti-diabetic medication, and patients who are already on injectable GLP-1 with poor compliance. They can be shifted to oral semaglutide. And in CKD, even up to EGFR, oral semaglutide can be used, unlike the SGLT2 inhibitors. In the Indian context, diabetes occurs a decade earlier, cardiovascular disease occurs a decade earlier, and the advantage of oral semaglutide is that it can be initiated early in the natural history of the disease and will help in blunting the disease progress. So in summary, oral semaglutide is the first ever oral GLP-1 receptor with safety and efficacy equivalent to injectable semaglutide established in clinical studies. Oral semaglutide provides good glycemic control by a disease-modifying approach and decreases HbA1c by 1.5% with minimal or no hypoglycemia. It decreases weight by 5%, which is a favorable effect on a variety of cardiometabolic parameters. And oral semaglutide is poised to improve the compliance, can be initiated early in diabetes to blunt its progress, and will prove to be a game changer. Thank you.
All right. Hi. My name is Osama Halak, and I am a cardiology fellow here at Kettering Medical Center in the United States. I'm very honored to have this opportunity to present in front of the camera for you guys, and hopefully you will enjoy this presentation. So my topic is about cardiovascular complications of COVID-19. Let's get started. I have no financial disclosures. So over the past 2 years, there's been a lot of information, a lot of data, a lot of studies that have been coming out. Pretty much everything related to COVID is getting published, regardless of the level of the data. Just if you go to the ACC and you type COVID in the search bar, you get about 27,000 results. Same for New England Journal of Medicine, you get about 800 results. So hopefully I've gone through some of it, and I can hopefully show you what's important and what's not. So unfortunately, this information is going to be outdated by the time you see it. But now, at the time of this presentation here in January, we are going through the Omicron surge. There are 320 million global cases confirmed since the beginning of the pandemic, with about 5.5 million, which were probably preventable deaths. Here is the global progress in terms of vaccination. As you can see here, we have quite a few countries that are about the 100% mark, so I applaud these countries for their efforts. As you can see, the top of the list is the United Arab Emirates. So that's actually where the conference is supposed to be. So maybe with this 100% vaccine rate, we can hopefully have this in person next year. So I've broken down my talk into four different aspects of COVID. So the first aspect is people that have a cardiovascular history, how did they fare when they had COVID? Two is people that have COVID, what are the cardiovascular complications of it? Three is what are the long-term cardiovascular consequences of COVID? And four, how has it affected the practice of cardiology here and worldwide? So as you can see here, this was a study that was published from New York with a little over 5,000 patients, and they took all the risk factors of the patients and they tried to get hazard ratios for mortality. And they found that age, here you can see purple means the patient was discharged alive, and orange means that they unfortunately passed or they were discharged into hospice care. So age here was, as you can see, the older you get, the higher the hazard ratio and the risk or probability of an event was, and the event being mortality. And then here by diagnosis, so patients with cancer diagnosis, diabetes diagnosis, heart failure diagnosis, and gender. So with a heart failure diagnosis, you can see these lines get the closest, meaning that they had the highest risk. So you can see the age over 75 has a higher hazard ratio of 7.69, heart failure diagnosis about 1.54, followed by a BMI of greater than 40 of 1.45. This was another study. This was a meta-analysis of 51 different studies with about over 48,000 patients published in 2021. And they found that patients with cardiovascular disease had an odds ratio of 3.15 to have severe COVID and 3.23 to have death from COVID, with a fatal outcome with their severe COVID or death being about 3.11. So how does COVID affect the heart? What are the direct cardiovascular complications? There's direct and indirect. Direct being if the virus enters the myocardium, you can have myocarditis. You can also have infection of the vasculature, which causes thrombosis, whether it's myocardial thrombosis like ischemia or myocardial strain due to PE. There's also, it affects the lungs, causing hypoxia, GI tract with diarrhea, kidneys can have renal injury. All of these things can have secondary impacts on the heart. So the hypoxia, of course, can lead to ischemia. It can also lead to, arrhythmias. Same for the intravascular volume imbalance, the electrolyte imbalance associated with these problems. The other thing was people were taking investigational therapies in the beginning. Remember hydroxychloroquine and azithromycin, both of which are QT prolonging medications. So this was a meta-analysis of 17 multinational studies with almost 6,000 patients. And they showed that this was the incidence of certain complications in patients with COVID. And heart failure here had 17.6, an incidence of 17.6% in every 100 patients, followed by cardiac arrhythmias at 9.3. So you can see there's definitely a large amount of cardiovascular complications due to COVID. Of course, troponin, if you have worked in the hospital, you've seen that a lot of these patients are having elevated troponins. And troponin does not always mean there's an acute injury or an ischemic injury, but it does mean that there is a myocardial injury going on. And so this kind of information is similar to what we've always known. There's the chronic myocardial injury if the delta is less than 20%. Acute non-ischemic injury due to primary causes such as myocarditis or primary non-cardiac causes such as sepsis or PE. And then there's acute myocardial infarction, type 1 and type 2 that we know. So here are a couple studies that looked at some imaging in COVID. So the first study is about 768 patients who underwent echocardiography. And they start by saying that troponin and BNP were elevated in about 36% of patients with COVID. And then they saw that LV systolic dysfunction measured by global longitudinal strain was in about 12.4% of patients and diastolic dysfunction in 28% of patients. Then there was this prospective observational study out of Germany with 100 patients who underwent cardiac MRI after recovering from COVID. And they found that a whopping 78 patients out of 100 had cardiac involvement on their cardiac MR, and 60% of them had ongoing myocardial inflammation. We don't know the clinical significance of this, but that's a very high number. This next study was a post-mortem analysis. There was analysis of 22 different publications, which were autopsy studies, and they found that myocarditis was present in about 7% of the autopsy patients. But after closer examination and more information that was reported, they found that most of them were likely not functionally significant, and the true prevalence is likely much lower at around less than 2%. This final study they used PET, and so they found that there was FDG uptake suggesting myocardial inflammation in patients that underwent PET. So is there a role for cardiac MRI in COVID-19 infection? So you want to think about acute infection and resolved infection. So in the acute infection, we now know that the prevalence of myocarditis is pretty low, probably about less than 2% based on those other studies. But you may consider doing a cardiac MRI in a patient that is presenting with new LV dysfunction or symptoms suggesting ACS, and you've completed an ischemic evaluation such as a coronary CTA, stress testing, and other testing, and you haven't really found a culprit, then you could probably do a cardiac MR and see if maybe they are having myocarditis. Of course, there's procedural implications when you have an MRI. Now, what about in the resolved infection? So the general population, we don't really recommend screening them for myocarditis, especially if they're asymptomatic. And then what about for athletes that want to return to their sport? So they've done some studies on this, and they found that although there may be a benefit, you should start by screening using first-line testing, such as an echo, an EKG, and a troponin. If you have any abnormalities in these testing, then maybe consider a cardiac MRI before giving them the green light to go back to playing their sport. But there was a large study that showed that the prevalence of myocarditis among athletes was about 0.6%. Now, what about when we talk long COVID? So the symptom spectrum in long COVID is pretty broad. People have brain fog, fatigue, some have chest pain, palpitations, etc. As cardiology, a lot of the patients that are referred to us have POTS, or postural orthostatic tachycardia syndrome. And really the management of that has been focused on physical therapy, compression socks, lifestyle changes such as hydration and salt balance, and then some people have used certain medications such as midodrine or other alpha blockers for orthostasis and non-selective beta blockers for palpitations. So now, how has COVID affected our practice as cardiologists? These are 3 different studies, all published around the same time from 3 different countries. Here, the top one is the United States, this was in England, and this was in Austria. And these 3 studies looked at the number of ACS or cardiac alerts that were called at these different hospitals, these different centers. And they found that there was a significant decline in STEMI numbers, about 40% actually at the start of COVID. And that was something that was seen in all 3 of these countries. They did find, however, that after a couple months, the numbers did slowly come back to where they were before. And then how about outpatient cardiology? So the gray is canceled or no-shows, white is patients that presented in person to their appointments, and blue is telehealth. And so you can see here there's quite a dip of the patients presenting to the outpatient cardiology clinic, and that lasted for a couple of months actually, and then slowly it's kind of coming back a couple months later. But we're probably seeing the consequences of these drops in care now. And now the last topic, which is the most the hot topic, which is the vaccination and the side effects of the vaccine. Now, this has become very politicized, very polarized, and what patients are seeing in the news or reading or hearing about on social media, and what's scaring them are these 2 complications, whether myocarditis with the mRNA vaccines or thrombosis and thrombocytopenia with viral vector vaccines. Now, they've done a bunch of studies. There have been a lot of case reports, of course, but a lot of other studies that showed that the incidence of these side effects or these complications is very, very low. And the benefit of the vaccine definitely outweighs the risk of having these side effects. So we would still strongly recommend and encourage you to advise your patients and kind of give them the reassurance that they should continue to get vaccinated, and it's probably going to be a lot more beneficial than it is harmful. So what are the areas for future investigation? I think these are 4 important topics that we could look at. So the prognostic value of a troponin, there have been some studies that show that the higher the troponin, the worse the outcome. But if there was a way to kind of quantify it a little better, that might help with making some decision making in the hospital. Cardiac MRI, it would be beneficial to know what is the clinical relevance of this inflammation that we're seeing. I mean, that other study showed 78% of patients had some sort of cardiac involvement. So we just want to see, is this clinically relevant? Is it significant? Should we do something about it? Return to play for athletes, and then long COVID. Just to know, what's the efficacy of the treatments that we're using for these patients with POTS, and what's the impact of long COVID on the ability of patients to return to work, their psychosocial well-being, and other long-term cardiovascular health. And so with that, I conclude my talk. Thank you. Sorry that it was very rushed and brief. It's a very big topic to cover in just a short 8 to 10 minutes. But I want to thank you for your attention. And if you have any questions, feel free to reach out to me. And I hope to meet you guys in person next year. Thank you.
I want to thank all of the speakers, chock full of information, as I promised, right? And we have only 5 minutes, and we have such great moderators here, Dr. Leila, Adjunct Clinical Associate Professor, University of Sharjah, Professor P.C. Manoria, Director of Manoria Heart and Critical Care Hospital in Bhopal, Dr. Nushin, Consultant Cardiologist, Dubai Health Authority. So I just wanted to give you guys that honor. And I think in the whole length and breadth of all these talks, I found one consistent message about endothelial dysfunction as probably the basis of all of these things, from Dr. Sammers talking about hypertension and hyperlipidemia being such risk factors for coronary disease, and ischemia, Dr. Magji talking about ischemic burden and when and where to intervene, and Dr. Leila and the Minoka, right? All the way to Dr. Halak, even the post-COVID syndrome. So I wanted and Dr. Manoria, right? Talking about what is semaglutide and how effectively making a change multi-organ. So I just wanted to give you guys the opportunity to talk about that. We don't have a lot of time, maybe 4 more minutes, and then we have to go to our symposium. Dr. Leila, what do you think about Minoka and endothelial dysfunction?
Well, it is very interesting topic, and unfortunately, Annie, women are usually 5 times commoner to get this case than men. And of course, we know this, the endothelial dysfunction is one of the main cause of it, and the microvascular diseases is one of the cause for it. And it's very difficult for patients, especially when you see them in the clinic, and they come back and then they have pain, and they come constantly, and you've done everything, and even to the extent you've done the angio, but they have pain, and you don't know what to do to them. I think we always say that the microvascular is the reason for it, and I think the controlling the risk factor in these patients and controlling the symptoms will be the best treatment. Although we said, as you've noticed in my presentation, not all of the risk factor is the conventional one is present in these patients, as we've noticed in the presentation. And the question which comes and says why women more than men, unfortunately, there's so much answers. It's still not clear about why do women get so many. It's more commoner in men than women, and so many questions we have about Minoka that has not been answered. One of them is the treatment plan. What's the best treatment plan for them?
I think that's a very important to discuss, especially about women. Dr. Nushin, what do you think about that you're in the UAE?
Yes, as physician, we talk about pathophysiology, endothelial dysfunction, and other factors in the pathophysiology of atherosclerosis. But when it comes to patients himself or herself, they don't know about endothelial dysfunction. If you tell them you have endothelial dysfunction, they would probably go and change their doctor. And that's where I think Dr.
Leila's presentation was very important because, you know, you have a patient that has normal coronary angiogram. If you have abnormal coronary angiogram, it's so easy to communicate. I mean, it's easier to communicate with the patient or patient's family. Look, you have 1 or 2 or 3 artery disease, so you have to do this. Is how you communicate this message to a patient that you say your coronaries are normal or they are not that bad. So how would you do that? That's the tricky one. And I think these kind of patients, they need more time for us to understand the whole concept. I'm not interventionist, but I always tell my patients that, listen, my colleague, Dr. Omar, fix your arteries, but it's the end of the story. It's not the end of the story. So in
Very
between
good.
the discussion, we go
Thank
on.
Thank you. Thank you. I think
Yeah.
we have 1 more minute left, and Dr. Minori, I wanted you to maybe take it another level. Like, what about nitric oxide and the endothelium and these nitric oxide deficiencies in these endothelial dysfunction patients? Is that important to look at?
Yeah. This oral semaglutide, the injectable semaglutide is a blockbuster for treatment of diabetes. It produces good glycemic control, decreases weight, and minimizes ASTVD. Now, the same is available in an oral form, so it will greatly improve the patient compliance. Less than 10% of patients across the globe who are eligible to take GLP-1 are taking GLP-1. So with this, not only more number of patients will take, but the adherence will improve. And it can be initiated early in the course of the disease because there will be no hesitation in initiating the therapy. And this will blunt the progress of diabetes. And if the progress of diabetes is blunted, CVD will be less because it targets 6 of the 8 components of the ominous octet.
And perhaps the endothelial dysfunction improves
Yes.
in that setting and increasing nitric oxide by the endothelium. So thank you all very much. You guys are amazing. I think we have now a symposium that we must go to, and that's going to be about acute coronary. Let's see here. Let me make sure. Yeah, time for ACT, sorry, for acute coronary syndrome patients. And that's going to be Amgen, Dr. Tukazuglu from Turkey. So, Dr. Tukazuglu, I just wanted to make sure I said that
Thank you.
properly in my text.
Thank you very much.
Thank you all. Take it away, Dr. Tukazuglu. We're waiting for your presentation and happy.
I'd like to start by thanking the organizers for their kind invitation. My topic is early lipid lowering in acute coronary syndromes. I'm Lale Tokyozol from Hacettepe University, past president of the European Atherosclerosis Society. Here you can see my disclosures. Atherosclerotic vascular disease is a chronic risk factor-driven disease which will ultimately lead to acute coronary syndromes. And the aim in preventive cardiology is to prevent the first or recurrent events. If a patient presents with acute coronary syndromes, this means that the patient has a significant atherosclerosis burden and at least one or more vulnerable plaques. There is a high likelihood of recurrent events, and the patient will need aggressive treatment. The unstable plaques that lead to acute coronary syndromes usually have a large necrotic core, macrophage infiltration, and have a thin fibrous cap. And when that cap ruptures, acute coronary syndrome occurs because of the thrombus that sits on top of it. So there are two mechanisms of acute coronary syndromes, the ruptured plaque or the eroded plaque, but both of them lead to thrombus formation and subtotal or total occlusion of the lumen. The Prospect 2 trial was an interesting imaging trial showing us the determinants of major cardiovascular events. And here you can see that the lipid content and plaque burden are the two important determinants of major cardiovascular events. So LDL lowering will have an impact on both the lipid content and the burden of the plaque. Why do we lower LDL cholesterol in acute coronary syndromes? First of all, there will be several other plaques in addition to the culprit lesion. Some or most of them will be vulnerable. And we want to decrease the lipid content and inflammation of these plaques and stabilize them. We want to slow the progression or even regress the remaining plaques so that we can prevent further cardiovascular events. There has been major success in lowering lipids to decrease cardiovascular events in the past decade, and by targeting different causal lipoproteins, we can significantly decrease cardiovascular events. So the new paradigm is from a shift from a high-intensity statin to high-intensity LDL lowering by any medication that will address causal lipoproteins. Statins have been around for a long time, and they're the most important part of lipid-lowering therapy. By using a statin, we know that we can decrease the lipid core of the plaque and increase the fibrous tissue. Imaging studies with CT have already shown us that also calcification increases when you use a statin. Here you see CTs of the same patient taken a few years apart, and you see that the calcification increases, but the plaque stabilizes when you use a statin. One step further is adding a PCSK9 inhibitor to a statin. The GLAGO was an intravascular ultrasound study in chronic coronary syndromes, trying to see how addition of PCSK9 inhibitor to standard therapy changed the plaque. And this study showed that there was even more regression. And if you got the LDL below 1.5 millimole per liter or 55 milligrams per deciliter, there would be either regression of the plaque or the progression would stop. And regression of plaques were seen more frequently in the PCSK9 evolocumab group compared to the placebo. Plaque regression is parallel to the achieved LDL. So the lower you lower the LDL, the more regression you're going to get, as you see in these different trials. Statins also cause plaque stabilization by decreasing the necrotic core and increasing fibrous cap thickness. Here you see the OCT 1 year after statin treatment, showing that the fibrous cap thickness is increased and lipid core decreased. The yellow study showed that with near spectroscopy, the lipid core shrinks with statins in around 7 months. So here you see the same patient control near spectroscopy, and the yellow part is the necrotic core with lots of fat in it, and it can regress by statin therapy. Is there a way to regress this earlier? Probably yes. Here you see a case where statin and ezetimibe were used to decrease the lipid content of the plaque, and even 1 month after an acute coronary syndrome, the non-culprit lesion near spectroscopy imaging showed that the yellow lipid content decreased significantly if you were able to lower LDL from 139 to 56 milligrams per deciliter. So speed may count. The Huygens is an important study and looks at the impact of adding a PCSK9 inhibitor to a statin on plaque phenotype after an acute coronary syndrome. So they started with 161 patients with non-ST elevation myocardial infarction, different LDL levels, and randomized them to placebo or evolocumab on top of standard treatment. And in the beginning and at the end of the year, the patients were evaluated by optical coherence tomography. The imaging analysis was done in a pre-specified segment, and the primary endpoint was change in minimum fibrous cap thickness anywhere in the segment. And the secondary endpoints were percent change in minimum fibrous cap thickness, change in average minimum fibrous cap thickness, and change in the maximum lipid arc, and at least 3 consecutive images were analyzed. At the end of the study of 12 months, 70 placebo completers and 65 evolocumab completers were compared. And follow-up OCT of the originally imaged target vessel was performed in 135. As expected, the LDL cholesterol went down significantly more with evolocumab than the standard treatment group. The baseline OCT measures were similar in the 2 different groups, but the primary endpoint was significantly better in the group that got PCSK9 inhibitor. Here you see the minimum fibrous cap thickness, and the fibrous cap is significantly thicker in those who got the PCSK9 inhibitor. The secondary endpoint of percent change minimum fibrosis cap thickness was also significant, so the cap thickened more with evolocumab treatment. The secondary endpoint of maximum lipid arc change was also met. You see that the lipid arc regressed significantly more in the PCSK9 inhibitor group compared to the standard care placebo group. Another exploratory endpoint was patients with on-treatment minimum fibrous cap thickness less than 65 micrometer. So these were the thin cap that would be at risk for higher events, and they were much less in the evolocumab group. The relationship between LDL cholesterol and changes in fibrous cap thickness were parallel to the change LDL cholesterol and achieved LDL cholesterol. So the lower you got, the better. Looking at adverse clinical events and safety findings, there were no significant differences between 2 groups. In patients with a non-ST elevation myocardial infarction, more intensive lipid-lowering therapy with the addition of the PCSK9 inhibitor evolocumab for 12 months on maximally tolerated statins resulted in greater increase in the minimum fibrous cap thickness and decreases in the maximum lipid arc, both throughout the vessel and within the lipid-rich plaques. At 12 months after non-ST elevation myocardial infarction, only 12% of patients treated with evolocumab, in addition to maximally tolerated statins, showed evidence of any region with a minimum fibrous cap thickness less than 65 micrometer, which is a feature associated with a high risk of plaque rupture. And the degree of benefit was directly proportional to the intensity of lipid lowering we were able to observe. All these are fitting very well with clinical findings. SWEETHEART is a recent study done in 40,000 ST elevation myocardial infarction patients. In these patients, they looked at major cardiovascular events by LDL change from the index event and showed that percent LDL lowering is important. They divided percent LDL lowering into quartiles of LDL reduction and showed that those with the highest reduction got the most benefit and the more significant reduction in cardiovascular events. We know from the 2 PCSK9 inhibitor trials that risk reduction continues even at very low levels without a threshold or a J-curve like we see in hypertension. So it's safe to go as low as possible. When a patient presents with acute coronary syndrome, the patient will be automatically at very high risk. So for them, we recommend at least a 50% reduction from baseline of LDL with a goal of less than 1.4 millimole per liter or 55 milligram per deciliter. The guidelines are recommending that in all acute coronary syndrome patients without the contraindication of statins or intolerance, it's recommended to initiate or continue high-dose statins as early as possible, regardless of initial LDL levels. This is a class 1 recommendation. And if the LDL goal is not achieved after 4 to 6 weeks with the maximally tolerated statins, then a combination with ezetimibe is recommended. This is also a class 1 indication. And if the goal is still not achieved with dual therapy, then adding a PCSK9 inhibitor is recommended. This is also a class 1 recommendation. So these are the 2019 guidelines according to the evidence back then. So in acute coronary syndromes, what they recommend is a stepwise approach where you check the goal twice, first at the first 4th week and then at the second 4th week, after which you can decide if you want to go with triple therapy. However, we know that there is a major problem with compliance with lipid-lowering therapies, even with statins. The initiation, execution, and persistence is very low, and we really need to engage the patient. We know from studies that patients are more likely to adhere if the drug is started in the hospital setting. Here you see the EURA-ASPIRE study results, looking at attaining targets in coronary artery disease patients from 24 European countries. And you see that most of the goals are not met, especially LDL cholesterol goals. The same study also looked at the patient journey, and we published that instead of escalating treatment after the patient is discharged from the hospital, most of the patients, almost half of them, de-escalate the patient, and about 10% totally stop the medication. And it will be important to give the optimal medication before they are discharged and try to maintain it. We know what is going to get us to goal. We know that with dual therapy with ezetimibe and statin, we will probably get about a 65% LDL reduction. And with triple therapy, if we add on a PCSK9 inhibitor, 85% reduction. We recently published the hypothetical LDL values achievable with different intensities of lipid-lowering therapies. So from the beginning, we already know what is going to get us to goal. For this reason, the European Atherosclerosis Society recently put together a paper recommending combination lipid-lowering therapy as the first-line strategy in very high-risk patients, similar to the hypertension guidelines. So in very high-risk patients, it will be logical to start statin and ezetimibe if we're not going to get the goal with statin alone. And there are cheap generic combination preparations, and it'll be easy for the patient to adhere. If the patient has extremely high risk, such as other vascular events, polyvascular disease, familial hypercholesterolemia, we may even consider starting triple therapy from the very beginning. So we know already that lower is better in ACS, but is earlier better? And which time frame should we reduce LDL cholesterol in acute coronary syndromes? And studies are emerging in this context, and we are trying to find it out. We know that LDL lowering by means of high-intensity statins will result in early clinical benefit within 30 days. We know that from earlier trials. That's why we give high-dose statins from the very beginning, the first day of the acute coronary syndrome. What about PCSK9 inhibitor trials? These trials were done all in very high-risk patients, but they did not get the medication during the index event, but a few months later. The first study to see whether we can start the PCSK9 inhibitor during the acute coronary syndrome is the EVOPAC study. And in this study, they looked at evolocumab for early reduction of LDL cholesterol in patients with an acute coronary syndrome. Patients were randomized to standard therapy, including intensive statin, and evolocumab added as a different group, and the two groups were compared. This study showed that the patients who got the PCSK9 inhibitor got a much better reduction in LDL cholesterol, so they were at much closer to the goal at the end of a month, and percent reduction in LDL cholesterol was significantly higher. There were no safety issues or problems or drug interactions, but this study was not large enough to mention clinical outcomes. Another small study, EVAX, was a double-blind randomized placebo-controlled trial in patients with non-ST elevation myocardial infarction. And here again, the patients were randomized to a PCSK9 inhibitor versus placebo on top of standard therapy. The LDL levels declined at day 1 and after evolocumab, and were significantly reduced compared to placebo by day 3. And significantly more patients got to goal at the 30-day follow-up. So early intervention and early LDL lowering is possible if you give the PCSK9 inhibitor during the acute coronary syndrome. Lipid lowering has several beneficial effects on the plaque. It can regress the plaque, it can thicken the fibrous cap, reduce the inflammation and lipid content. So giving it earlier will have certain benefits, but this still needs to be proven by outcome trials. Another way to change the plaque is the omega-3 story. We know from the REDUCE-IT trial that it's possible to decrease cardiovascular events using high-dose icosapent ethyl. Of course, this was not in an acute coronary syndrome setting, but we have the EVAPORATE trial, which is an imaging trial looking at the effects of icosapent ethyl on the plaque. And here you see there is a major effect of changing the low attenuation plaque, which is the plaque with the big necrotic core. So the major change in that plaque is seen when you give icosapent ethyl. This medication works in a different mechanism than other LDL lowering medications. It doesn't increase calcification like statins. It decreases inflammation and increases resolving of the plaque. So maybe in the future, this may also be tested in the setting of acute coronary syndromes. For now, we have to keep in mind that all patients with acute coronary syndrome have a substantial risk of recurrent events, and we should do our best to reduce these events. Modulating the plaque phenotype may contribute to early reductions in cardiovascular risk and stabilize the vulnerable plaques. So it's very important to do more research on very early combination therapy in patients with acute coronary syndromes. We already know that getting to guideline recommended LDL cholesterol goals and staying there will prevent cardiovascular events. So I would like to stop here and thank you for your attention. I will be happy to answer any questions you may have. Thank you.
Wow. Dr. Chakazugla, that was excellent presentation. We thank you. We thank Amgen.
Well, it was a really great presentation as usual, Dr. Lyle. It was really good. And of course, the idea of using the PCSK9 in emergency room for acute coronary syndrome, it's really makes sense idea because you want to have a quicker aggressive lowering of the L and usually in hours or days, instead of waiting for 30 days to see the effect of the statin. And clearly you said that if you start with the LDL 160 or 180 and you drop it 50-60%, you're still far from the target. So it makes sense to have really aggressive. I mean, you take just a shot in emergency room, and you can reevaluate after, let's say, a month to see if you have to continue or not. But I mean, you mentioned about the safety. I mean, the main concern is safety. It is seem to be safe, and probably, as you said, we're looking for a clinical outcome. So it make a full sense to get aggressive from the very first hour patient seen in emergency room.
Fully agree.
And if Dr. Samer, as he said, 39% of all death in the UAE is cardiovascular death. And as Dr. Lally was saying, most goals are not met, right? So there's this disconnect, right, in what we know and what we should be doing. So I think Amgen and maybe other industry leaders should be really focused on educating the doctors as well as the patients.
It's the idea of acute inflammation during acute coronary syndrome, of course, plaque rupture and so on. How much the LDL, because we know LDL playing a role in the inflammation, how much the LDL playing a role in that time, and how, I mean, the idea is if it's playing a role in that time, significant role, that make us more really aggressive, lowering quicker, faster.
Autopsy studies have shown us that most of the acute coronary syndromes occur from ruptured plaques. And usually ruptured plaques tend to have a very high lipid content. However, in statin-treated patients, recently we're seeing more eroded plaques, and they seem to be more common in women and smokers. And in the eroded plaques, inflammation is playing a slightly larger role, and their lipid content may be less. So we are able to determine by near spectroscopy or OCT the content of the plaque and can evaluate it per patient. But since not all patients are going to get the interventional diagnostic technique, this is not a practical way to approach things. But we know that even the normal LDL cholesterol levels, which we assume to be normal, are very high. I'm sure you've all read Professor Brownwald's editorial about how to live to 100 and going all the way to the bottom with LDL cholesterol, where he recommends that having an LDL between 30 to 50 is good enough for us, and anything over that is too much. So I think even in those plaques, LDL lowering will be efficacious.
Dr. Leila, and the oxidation of that LDL, maybe that's what Dr. Omar was indicating, even those Minoka patients.
Yeah, in the study, do we have data about the high sensitivity CR for patients who receive the PCSK9 inhibitors versus the placebo in acute coronary syndrome setting? Do we have did that change the level of the CRP?
That is not announced yet, but we know from other studies, not done in the ACS, but post-ACS setting, that they do not impact the high sensitivity CRP. And their analysis from both the Fourier and the Odyssey trials showing that if a patient reaches very low LDL levels, but still has very high sensitivity CRP, they're likely to be at more higher risk. And Professor Ritker is always advancing that a combination of both anti-inflammatory and PCSK9 trial should be done, but that will be very difficult.
I mean, you can give a couple of tablets of colchicine
Exactly. And in the European guidelines, now it's a class 2B recommendation to give colchicine if there is residual risk. So we'll be hearing more about that, I think.
Yeah, I'm sure. The problem with the colchicine is so inexpensive. So,
so they won't make a trial.
Yeah. So, I mean, if you give the PC, let's say we start to giving those PCSK9 inhibitor in emergency room, and after 1 month you find out the LDL is 10. Do you continue? Do you lower the statin? Do you stop the PCSK9 inhibitor? What I mean, what do you do?
First of all, we do not trust the LDL measurements with a Friedewald formula. If the LDL is very low, it may be calculated to be 0. There are better equations, or you can actually do the ultracentrifuge and check. So first of all, it's usually not that low in reality if you can measure it. And the second is if it's really, really low, I never downgrade the treatment if the patient is feeling perfectly normal. But probably pushing below 30 milligrams per deciliter is not going to have much additional effect. So in the medium term, short term, 2.5 years or so, it's safe. We don't know about the long effects. But in general, we did not de-escalate the treatment unless there were any side effects or problems.
I noticed that, I mean, when the high dose of statin, they are more likely to have elevated hemoglobin A1C. I do hemoglobin A1C kind of routinely now in my practice, every 3 months or so. And I noticed that when you have a high dose, you have more likely to have higher hemoglobin A1C. And that's the reason when the LDL, as you said, about 30 or less, I tend to lower the statin. I don't know if that's right or wrong. What do you think? I mean, especially if the hemoglobin A1C start to go up a little bit.
Yes, we know that statins may increase the dysglycemia slightly, especially in higher doses, and especially if the patient has metabolic syndrome or borderline hemoglobin A1Cs. So that sounds like a logical approach. Plus, people usually complain of myalgias with high-dose statins. However, we have no evidence to support it. I would love to see a trial because giving it early on is fine. But what do you do in the long term is another question. In the Fourier and Odyssey outcomes, you all well know that the statin dose was not de-escalated. So we don't really know how that is going to work.
Okay, that was really great. I mean, Annie, do you have any question?
I think, so that's what, I'm always talking about oxidative stress. So the PCSK9s and oxidation and, there is it hasn't been released, I guess, all of this data about what they do with oxidation.
Yeah.
But
I mean,
having the LDL low, I still see patients coming in with acute coronary syndromes, right? So I think that it's so important to lower the LDL and then address this oxidative stress inflammatory pathways. C-reactive protein is not enough. We know it's only about 35% sensitivity versus the pulse cardiac test, which is like about 75% sensitivity, as I spoke in my talk. So lots of things to learn about oxidation and inflammation.
Yeah, and now interleukin-6 inhibitors are being tested. Yes. So that might be even a better way to stabilize the inflammation.
Yay, can't wait for that.
So we have the bag of the medication of the acute coronary syndrome getting bigger and bigger. I mean,
that is true. So true. Just like
we have a statin, ezetimibe, PCSK9 inhibitors, anti-inflammation.
We'll really need to personalize in the future.
Absolutely, absolutely.
Right, and genetic testing may come in, right?
Yes, for sure.
Well, it is somewhat, I mean, in some of the practice and kind of start to be applied somewhat, and probably that's a way to, as you said, tailoring the treatment. Probably one medicine work better for one patient versus other patient, and yeah.
Exactly.
Well, it was really great to have you, and you, as always, excellent talk, very informative, straight to the point, and we learn a lot. This is a treat.
Thank you so much, and hopefully next time
something new.
Yeah.
The thing is, yeah, hopefully we'll see you next year in Dubai. Yeah, again, as we used to be to do. Yeah. Well, thank you so much. We are kind of a little bit behind the time, and wish you have a bit more time for discussion, but I guess the next session are waiting for us. Thank you so much. It was great to have you.
Thank you.
Thank you, Dr. Leila.
Thank you, Annie.
Thank you. Okay, we have a lot of speakers in this next session. It's going to be amazing, and it's going to be the end of our Great 4TS 2022. So I'm kind of sad.
Hi, Dr. Omar. Good evening, Dr. Omar.
Hi, great to see you, Dr. Mahabatra.
Good evening. Good to see you. Yes. Dr. Omar, how are you?
Okay.
Going very
Doing
well.
great. Thank you so much.
Good. Good. Good.
Happy to have you. Thank you so much for being with us.
Thank you, sir. Give me an opportunity.
Dr. Omar, I have some introductions, so I just wanted to say a few
please.
introductions. All right, so we have Dr. G.N. Mahapatra, Head, Department of Nuclear Science, Bhatia Hospital, Mumbai. Dr. Samar Elaham, Senior Cardiovascular Consultant, Cleveland Clinic, Abu Dhabi. Dr. Mohammed Salah, Head of Cardiology Unit, New Kalba Hospital, MOH in Sharjah. Dr. Amrish Agrawal, Consultant Cardiologist in Fujairah Hospital, UAE. Dr. James Jenkins, Section Head of Interventional Cardiology, Director of Research, John Oshner Heart and Vascular Institute. Dr. Razan Halak, Registered Dietitian, Nutritionist, Ohio State University. And Dr. Lauren Barron, my good friend, Clinical Professor of Medical Humanities at Baylor University in the USA. So we're going to get started unless Dr. Halak has anything else to say. I will tell.
We'll just keep going. We're
keep
very excited
going.
to hear the speakers.
Thank you all.
Hi, good evening. I'm really obliged to Dr. Omar Halak for giving me an opportunity to speak on multifaceted role of PET in clinical cardiac practice. This is my 7-inch hospital in Mumbai. So nuclear cardiology has made significant advances since 4 decades in the evaluation of left ventricular perfusion and function. But the current state of the art of the gated myocardial perfusion SPECT offers valuable diagnostic and prognostic information for the evaluation of patients with suspected and known coronary disease. After that, advances in the cellular molecular biology of the cardiovascular system has helped the user in a new modality in nuclear cardiology, that is molecular PET imaging. Nuclear cardiology procedures, as you know, including PET, have distinct advantages over other diagnostic imaging modalities, such as having a low radiation risk because of low amount of radioactive are used. It is being relatively painless and non-invasive, provides both structural and functional information of the organ of interest, superior to other non-invasive tests like routine ECG, stress ECG, 2D echocardiography, MDCT, and MRI, with a sensitivity of 93% and specificity of 95%. New innovations, such as molecular imaging, now offers an array of tools to develop advanced diagnostic approaches and therapies for patients with CAD and heart failure. Understanding the pathophysiology of atherema, the PET has a very big role, makes it possible to identify vulnerable plaque from a stable plaque based on its metabolic signature or the presence of excessive apoptosis. Because of its larger metabolic and apoptic signals, even small lesions can be visible. What are the various clinical scenarios where PET scores over other modalities? Role in obstructive flow-limiting lesions in patients with CAD, role in non-obstructive flow-limiting lesions, particularly of atheromatous plaque, stable as well as unstable plaque, role in patients with myocarditis and associated cardiac inflammation, role in patients with chronic infiltrative myocardial disease, then role in gold standard assessment of myocardial viability, role in estimating coronary flow reserve as against FFR, either catheter-based or CT, then role in molecular targeted imaging, but role in molecular targeted therapy. So all these multifaceted role of PETs, you cannot be covered in such a small time, but I'll try my best to just give an overview. So first in the list, various types of cardiac PET CT procedures in CAD, stress PET myocardial perfusion study for detection of stress-induced ischemia. The radioisotope PET images, radioisotope used in PET, stress nitrogen-13 ammonia, stress rubidium-82 myocardial perfusion study, stress effect in FDG heart imaging, stress effect in proofreaders, which will be introducing very shortly to the myocardial perfusion study. So if you see here that there is this is a rubidium study, you can see stress and rest PET studies, and you can see there is no this is a normal perfusion, the ejection fraction is 54, increased to 63%, there is no perfusion abnormality. But if you see here, there is a posterolateral, there is a defect over here, which is reversible with a resting image, then the ejection fraction falls from 60% to 49%. So stress affected proofreaders, stress imaging is visible with both treadmill exercise and pharmacological vasodilation. So myocardium is clearly visual. It is a breakthrough innovation of radiopharmaceutical as compared to TC90M SPECT MPI with respect to rest stress image quality, certainty of image interpretation. Sensitivity is very high. So you can see here the proofreaders images, stress and the rest. So this is a normal PET perfusion, stress perfusion, and the coronary angiography is normal. So here you can compare the SPECT. It has got a very good sensitivity specificity. You see now here there is a perfusion defect which is reversible in SPECT, but in PET proofreaders it is normal. So it scores over SPECT by a 5 to 6%. Here also same thing in the SPECT image. You can find here there is a perfusion defect but false. But if you see the proofreaders PET imaging, it is a normal. This is the same thing, anterior wall, there is a defect showing a reversibility, but in PET it is showing normal. So here the sensitivity is increased by 5 to 7% as compared to SPECT. So PET has got increased sensitivity and increased specificity in the detection of myocardial ischemia. Then comes the next use of PET is called the coronary flow reserve and myocardial flow reserve. Absolute quantitation of the myocardial blood flow and coronary flow reserve is an established method of quantifying the blood flow in individual coronary artery. Recent studies have suggested a role for coronary microvascular dysfunction, particularly in HFpEF, heart failure with preserved ejection fraction. Cardiac PET is a non-invasive quantitative imaging modality capable of accurately quantifying myocardial flow reserve, the ratio of myocardial blood flow at peak stress to myocardial blood flow at rest. In patients without significant epicardial disease, myocardial flow reserve can be considered as a marker of microvascular dysfunction and a surrogate for coronary vascular health. The myocardial flow reserve or the coronary flow reserve has been shown to have a prognostic value in patients with HFpEF. Myocardial flow reserve may be reduced in HFpEF patients compared with controls without heart failure, representing microvascular dysfunction. HFpEF is associated with a lower global and regional myocardial flow reserve than non-heart failure controls. The mean global myocardial flow reserve is 2.16. HFpEF, which is significantly lower compared with 2.5 in hypotensive control and normotensive control. What are the PET tracers available? Oxygen 15, nitrogen-13 ammonia, rubidium-82 chloride, and effect in proofreaders. So here you can see the PET tracers. This is nitrogen-13 ammonia on the left side, the rubidium-82, and the oxygen. With these three images, we use the help of nitrogen-13 ammonia and rubidium. With the oxygen-15 water, the image quality is degraded. So here we take the serial image, right ventricle, left ventricle in the least mode. Then we can see the calculate the coronary flow reserve at hyperemia and flow at rest. So you can see 45-year diabetic patients, more than 5 years, the stress, rest, nitrogen 13 cardiac, ammonia cardiac PET, showing normal perfusion where the coronary flow reserve is more than 2. This is normal. But if you see another abnormal patient of a diabetic, 59, a patient with a history of 8 years, the cardiac PET perfusion reversible, there is a defect in the lateral wall circumflex territory and which is reversible. This is a nitrogen 13 ammonia study where the LCX coronary flow reserve is 1.29, much lower. So role of CFR in evaluating triple vessel disease and balance ischemia. Patients having significant multivessel lesions or in patients having balance ischemia with global reduced perfusion pattern, interventional cardiology will be confused of the following. Which is the culprit vessel to be intervened on priority, whether single vessel or multi-vessel. So CFR estimation on individual artery would guide the cardiology for the right direction to go when you will not get these answers either from CT FFR or catheter FFR. So here you can see this is a balance ischemia showing the reduced perfusion pattern in all the territories, something normal also, but here coronary flow reserve is abnormal in all the territories. LAD 1.1, LCX 1.4, RCA 1.1. So mismatch stress rubidium 82 and CFR parameter. Coronary flow reserve quantitative parameters which are lower than the normal level in the presence of uniform stress perfusion pattern in the defined myocardial segment by rubidium 82 study would definitely detect this is not the culprit artery to be intervened. So then what? Stress perfusion defect present along with the CFR parameters will reduce. This is the culprit lesion which is to be intervened first. You can see here. The perfusion is normal in the anterolateral and anteroseptal, but here posterolateral and inferior there is a defect, and also the lesions are there 1.07 and 1.03. So this is the culprit artery to be intervened first. Detection and monitoring of cardiac inflammation. F18 FDG PET-CT imaging has been an emerging promising diagnostic and therapeutic monitoring tool for cardiac inflammation, particularly of post-MI, infective endocarditis, implanted cardiac device, infiltrative cardiac disease such as sarcoidosis and amyloidosis. So these are the cardiovascular inflammatory things: sarcoidosis, amyloidosis, myocarditis, vascular disease, atherosclerosis, vasculitis, Takayasu arthritis, giant cell arthritis, where it can detect. So coming in the first in the list, F18 FDG, vasculitis is defined as an inflammation and necrosis with leukocyte infiltration of the blood vessel. Takayasu arthritis is a chronic inflammatory arthritis that primarily involves the aorta and its main branches. F18 FDG PET-CT metabolic imaging is nowadays used for the investigation of the patients with large vessel vasculitis along with Takayasu arthritis. And it reveals the extent of the disease and is highly effective in detecting large vessel vasculitis anywhere in the body and has a high sensitivity and specificity. It can be monitored, particularly of large vessel inflammation and disease activity after the immunosuppressive therapy, such as prednisolone and cyclophosphamide, you can give and repeat the scan following 2 months after the therapy to find out whether the PET-CT is doing good. And here you can see here the Takayasu arthritis, both subclavian arteries involved, and here the whole abdominal aorta is involved. Then the patient has been put on steroids and cyclophosphamide. See the repeat of the test after the year. See, now everything is gone. So now the patient is totally normal. The Takayasu arthritis has been resolved. So this is called the arthritis, giant cell arthritis, and also there is a uptake in the abdominal aorta, which you can see, and now it is totally gone with the treatment. This is affecting FDG for septic embolism, infection endocarditis, a severe disease that is diagnosed using combination of clinical and microbiology and imaging data. So infectious embolism can be asymptomatic to be recognized with the result of multiple imaging techniques like CT, MR, and ultrasonography. The existing imaging techniques are time-consuming, cumbersome, unable to perform or survey the whole body to locate the metastatic involvement. So you can see here there is the uptake here in the this images in the valve area. So this is a 33-year-old man showing uptake here, and you can see here the valvular ring and is infected. So it is showing the effect in FDG uptake. Here another patient, inflammation. Then after the treatment, the inflammation is gone. So this is a very interesting case. Patient had earlier a left-sided, right-sided cardiac implant with a device with the two this thing. There's a lead now which is floating. So that lead got displaced, and then the doctor has to take out this cardiac implanted device, and then the doctor put another one. So this area, the patient complains of rigor and chill and fever. So now you can see here the typical focal area of avid FDG uptake seen at the previously implanted pacemaker, where you can pinpoint that this is the site of infection for which patient is having rigor, chill and fever. Patient got treatment and again came back to normal. So this is the same patient where you can see here, this is the uptake area. So goals assessment in myocardial viability, all of you know viability, that revascularization would improve the cardiovascular outcomes, reduce heart failure symptoms, reduce admission to the hospital, and improve quality of life. The amount of viable myocardium above the threshold is 20%, the likelihood of benefit of revascularization increases. The outcome with this level of viability when the patient is managed even medically undergoing revascularization. These are the radioisotope, fluorescein purpurias, effect in FDG, rubidium-82, and the viable myocardium is ischemic or geoparadise, stunned or hypertrophic myocardium is ischemic, non-viable myocardium is scarred myocardium. Where is the first patient, we can see ejection fraction is 23%, here you can see 23%, and there is no signal system thickening. Here you can see the image here, there is a perfusion defect in the anteroseptal wall, and which is totally reversible in the PET image, which is showing the viable myocardium. Here the patient is in a failure, bilateral pleural effusion, where you can see here the ejection fraction is 21%, and here you can still say the viable myocardium is there at the septal and the anterior wall, and the patient was subjected to angioplasty, and patient recovered from the heart failure. This is a fixed defect where the perfusion is are not there, and the PET metabolism is not there. This is called the match pattern. The patient has got a scarred myocardium. So detection of infiltrate cardiology, amyloidosis, and sarcoidosis. Sarcoidosis knows are responsible for 30 to 80% of death. And the Langa et al. They performed a retrospective study. There's a focal diffuse FDG uptake. The ejection fraction 56%. Here you can see the uptake here. These are called the active sarcoidosis is present there. Here. So this patient and the sarcoid different group, normal, mild abnormal, moderately, then the pre-steroid therapy, then after therapy, you can monitor the sarcoid improvement in this. Then coronary plaque imaging, the atherosclerosis, leading cause of mortality caused by fatty streak development, plaque information. And here you can just stable plaque and vulnerable plaque on the right side. And who are the patient who benefited acute coronary syndrome patient, asymptomatic type 2 diabetes mellitus, continuous chest pain lasted for 30 minutes, left bundle black, elevated cardiac markers, chronic stable angina patients. And the other radioisotope used, but best radioisotope which you use is called sodium chloride and 18-fluorodeoxyglucose for large vessel arteritis. But the copper 64 dotatate, gallium 60 dotatate are on the verge of coming. So this is here you can see the large vessel abdominal aorta. These are the atherosclerotic plaque, which is seen here, which can be detected by the effect in fluoride imaging. Here you can see this is the plaque which is in the LAD territory, which you can see the atheromatous unstable plaque in the proximal LAD territories. And patient under this is another patient, sodium chloride underweight, demonstrate 3 discrete lesions, which you can see the right coronary, there are 3 distinct atheromatous unstable plaque sitting on the right coronary artery. But whereas the LAD, there is no atheromatous plaque, there is no uptake here in the sodium chloride. So this is also another case where you can see the long vessel segment arteritis, and here concluding radionuclide imaging of myocardial perfusion, function and viability has always been a centerpiece of clinical practice in nuclear cardiology and serves as a reliable tool for therapeutic guidance in ISG. Today, molecular imaging of the heart is increasingly requested by cardiologists for infection, inflammation, and infiltration in the cardiovascular system. Nuclear cardiology procedures are no doubt the state-of-the-art procedures in the present-day clinical cardiac practice in diagnosis, prognosis, and guidance of therapy in CAD and non-CAD patients. This specialty has grown tremendously for the last 4 decades with the introduction of the new imaging agents, modification and innovation of new technology instrument, as well as addition of various quantitative software has further widened its horizon in the era of multimodality imaging. Procedures are cost-effective as well as promising, having an increased sensitivity and specificity with increasing interest in early detection and stabilization of vulnerable plaque, regression of established atherosclerosis, prevention of heart failure, and reversal of LV dysfunction. Nuclear imaging is moving towards developing newer tools and techniques to facilitate this development. This trend is further fueled by the advent of an increasing spectrum of novel molecular targeted drug intervention in cardiology practice and holds a strong potential for a future role in precision cardiology. FDG PET is not the emerging giant, but is an established giant in determining the amount and extent of viability since more than 1.5 decades. Patients with known or strongly suspected CAD, moderate to severe LV dysfunction, moderate to large persistent perfusion defects with
Hello, I hope you're doing well. My name is Dr. Samer Alaham. I'm a cardiologist with an interest in digital health. In the next 10 minutes or so, I will briefly go over an interesting topic, I hope, to all of us, update on the role of blockchain in cardiology. I have nothing to disclose. This is briefly the outline of my talk. Whether we are in Cleveland Clinic, Ohio, my employer, or Cleveland Clinic, Abu Dhabi, digital health, digital transformation is really the present and not the future. So this is something we're going over, all of us, and I'm sure you notice it at different layers. As cardiologists, we need to have at least an idea of digital health. I discussed previously artificial intelligence, and working with my colleagues at Khalifa University, we were able to humbly do quite a bit of research and studies looking at blockchain in healthcare. I'd like to share with you in the next few minutes. Telemedicine, telehealth, where I'm on the journal, also talks very frequently about blockchain. So it's not only related to artificial intelligence, but also to telehealth and many other areas in healthcare. As you know, healthcare is very complex, whether we are cardiologists or any other specialty. The way to align is really to focus on the patients and the caregiver, and I think all of us agree on that. And we know that healthcare has remarkably advanced, or at least changed. And we no longer necessarily think of healthcare as being focused on hospitals or even clinics. Currently, almost all of us have iPads or smartphones, and very importantly, patients can access healthcare now in different ways. This is part of the continuous improvement, but also part of the digital disruption. And COVID-19 made it even faster and quicker and more efficient and more valuable to get digital health. So now we talk more about the digital hospital rather than the typical hospital, and I'm sure you agree with me. I discussed previously with you that artificial intelligence has significant impact on quality, flow, diabetes and other chronic disease management, COVID-19, frailty, which is very important for us in cardiology, and even precision medicine. However, the topic today is on something different, which is blockchain. So what is blockchain? As the name suggests to you, it's a block in chain. The idea behind it is that you have no central authority here. There is no third party. So for medical record, for example, if you want to access my medical record, you need my own permission, and I would know when you access the medical record. From a cybersecurity standpoint, if the blocks are in chain and someone intervenes with any one of the block, the whole system shuts down. And it is a remarkably higher cyber security system. It has what we call a digital ledger, almost like a contract, and then the information usually is distributed in a very interesting fashion. So we talk about internet, cloud, and then the next one is a blockchain. You know, in healthcare, we have issues with accessibility, accountability, transparency, data sharing. We've written quite a bit on research and blockchain, reproducibility, and personal data privacy, which is important to all of us. The advancement in AI and machine learning makes it even more important with the huge data that we have to have blockchain. Data security is a must, and that is where we talk about blockchain. Quickly and briefly, there is a transaction, you know, a patient record is accessed, something financial, anything that you do. A block then is a representation of the transaction created. It's sent to every node of the network, all these blocks. The nodes receive the reward and the finding, and the block is added and the transaction is completed. But you know, these are series like a domino. If you affect one, you can shut down and stop everything else if it's not secure enough. So it is decentralized, it is transparent, it's immutable, it's autonomous, and it's anonymous. So in cardiology, it has numerous applications like in healthcare, and the applications are really related not only to cybersecurity, but many other aspects, especially of artificial intelligence. The application also is huge in clinical care and research, and we've published a lot with my colleague at Khalifa University related to this. I invite you to look at our publications. Blockchain data sharing and precision medicine is even more interesting when you get into electronic medical record. And very basically, what you do here is that there is a more efficient way to transfer and share the data. You have control of the data, and it's very cyber secure. And then the most important is when you relate it to artificial intelligence and machine learning, it's a very good combination. Now, we may or may not think about this. Hopefully this will never happen. But, you know, with all the pacemaker and the devices inserted in cardiology, just imagine, God forbid, that there is a safety issue in that. And this is what the FDA communicated recently. So really talking about the Internet of Things and blockchain would markedly improve our security, and we'll have better access to the physician and the patient. And there are several examples. I only have a few minutes left to address examples of blockchain and cardiac robotics. And this is one example. This is a publication we've had on blockchain using smart contracts, we call them, which is another step advanced in blockchain in telehealth. And I invite you to look at this. You know, the idea of this presentation is only to introduce us to this concept. This is another one looking at telehealth. And we've had several additional publications showing that this decentralized, immutable, transparent, open source access and auditable access, which is practically anonymous, can not only markedly increase the efficiency and efficacy in healthcare in general, taking care of the patient, but also has huge implications on data accuracy, cybersecurity, and very importantly, research, clinical research. These are opportunities for blockchain on something very clinically relevant for all of us: telehealth technology and telemedicine, patient consent management, traceability, secure access to the medical record, trustworthy monitoring of elderly care services, again, trustworthy health insurance services, reputation aware management, and automation. So many things that, you know, we're very familiar with telemedicine, I'm sure, and many applications there. These are several of the publications. I invite you to Google my name and put blockchain, or my colleague, Professor Khalid Salah from Khalifa University, and all the other outstanding colleagues that I'm honored to collaborate with. Technical limitations, obviously you need an investment in blockchain. Please be aware that the government in UAE, especially Dubai and Abu Dhabi, already invested in blockchain. And obviously you need to have an interest in that. Initially, blockchain will be a little bit slower, but it's moving very quickly, especially with the smart contracts. And there are several applications, and these are some names. Some countries are very interested in blockchain. One of them is United Arab Emirates, where we practice, and it's our honor, and also Estonia, among other countries. In conclusion, features of blockchain including decentralization, where you and I can know who's accessing the record, distribution, which anyone can see immediately, immutable, transparent, and being hack-proof makes it really very appealing. Cardiology-specific applications are many, and I will only mention a couple things related to insurance, related to robotic devices, artificial intelligence, prevention of medical fraud, and improvement in research. And we've had a couple of publications on research and blockchain. Huge innovation. The benefits I already mentioned, so I will not repeat them, but basically it's very secure. You can look at things quickly and know who's on. It can be distributed quite quickly, and data sharing is amazing for clinical and research. Future direction, we need further refinement of the system and emerging new technologies, but the most important thing in future perspective is to be aware that that thing exists and accept the change. Digital health and digitization and digital transformation are here to stay. And very importantly, with all the data that we have, millions and millions of data in hospitals, clinic, countries, we can have better use with AI, artificial intelligence, and with blockchain. And again, at the end of the day, we go back to the basics. We need to be reliable. We need to listen to each other, learn from each other, and lead together. But the applications of blockchain are numerous. Anyone interested in knowing more about blockchain or collaborating in the field, your humble student and colleague, Dr. Samer, myself, has the contact, and please reach out to me. I'll be happy to work with you and learn from you. Thank you very much.
Good evening, everybody. I'd like to thank the organizing committee and Professor Dr. Omar for inviting me to this prestigious conference. I am Dr. Muhammad Salah. I'm the cardiology consultant and the head of cardiology unit in Kalba Hospital, EHS, and the professor of cardiology in Suez Canaan University, Egypt. And I'm gonna to share my screen now to start my presentation. I hope that you can see my slides. My talk today is about navigating the realm of NOAC in hard-to-treat patient with valvular heart disease and coronary artery disease, prosthetic valve, and patient with TAVR. As we know, atrial fibrillation is one of the commonest arrhythmia worldwide, and the incidence for atrial fibrillation in middle-aged men or 40 years old is 26%, and for women is 23%. And the prevalence increases stably with age. As we know, NOAC is considered now as the gold standard treatment for the non-valvular atrial fibrillation. We have 4 types of NOAC available. We have dabigatran, rivaroxaban, apixaban, and edoxaban, which was studied in Engage AFib TIMI 48 trial. And all of them show that they have superior effect as safety-wise and efficacy-wise in comparison to vitamin K antagonists in treatment or dealing with patients with non-valvular atrial fibrillation, and they prove to have class 1A indication in all guidelines. But now let us move to discuss some important patient group, subgroup of patients that are difficulty or medically difficult to treat. Patient with coronary artery disease. In Engage AFib TIMI 48 trial, there are 4,500 patients with prior coronary artery disease. And they studied in this group, they showed that edoxaban efficacy, it was even better in patients with coronary artery disease with greater reduction in ischemic event. What about the bleeding tendency? Edoxaban safety is not affected by coronary artery disease with less bleeding in comparison to warfarin. Then look at this coronary artery disease in NOAC meta-analysis. I like this slide because as we can see, in all NOAC, they showed that they have a greater benefit in reduction of stroke systemic embolization in comparison to warfarin. But The odoxaban show more than 35% in addition in reduction of the incidence of stroke. What about the measure bleeding safety-wise? All the NOAC in the meta-analysis the trials show they are effective and as warfarin with less incidence of bleeding, and odoxaban shows that they are more than 19% risk reduction of bleeding in favor of odoxaban on top of the others. What about the cardiovascular death? They show the same finding. They create less incidence of cardiovascular death in favor of NOAC in comparison to warfarin, and odoxaban showed more than on top of this 31% risk reduction. If we look to the NOAC FFBCI trial, and we look to the safety-wise, as in terms of the bleeding, ISH measure bleeding or CRM bleeding, we can see that all the NOAC are in favor of less incidence of bleeding in this trial. Even we use the dual antiplatelet therapy in comparison to vitamin K antagonist when we use triple antiplatelet therapy. Let us move again to another subgroup of patient with valvular heart disease. And they look into the outcome patient with left side valvular heart disease. We know that NOAC is contraindicated in patient with prosthetic valve and severe mitral stenosis. Apart from this, we can use NOAC in the treatment of non-valvular atrial fibrillation. However, in the ENGAGE AFib trial, they found that a subgroup of patients with valvular heart disease, about 2,900 patients, and they either randomize this patient either to warfarin, odoxaban higher dose, 6 milligram OD, or odoxaban lower dose, 30 milligram OD. 60 milligram is the approved dose for prevention of atrial fibrillation. 30 milligram can be used when the patient creatinine clearance 15 to 50 and the body weight less than 60. And as we can see, in patients with valvular heart disease status in the odoxaban arms, there is a significant reduction of the stroke and systemic embolization in comparison to warfarin arm. There is also reduction benefit in patients with non-valvular heart disease. What about the safety-wise or bleeding-wise? The major bleeding is very less in the valvular heart disease arm. We're using the odoxaban in comparison to warfarin arm. And also, with no valvular heart disease, the incidence of bleeding is less. So, now let us move to biprosthetic valve. Let us speak about odoxaban for the prevention of thromboembolism in patients with biprosthetic valve, again in the same trial, in ENGAGE AFib TIMI 48 trial. They look at the outcome in patients with biprosthetic valve randomized to odoxaban versus warfarin. 191 patients with left side biprosthetic valve, 131 and 69 mitral, 31% aortic. And they look for the incidence of stroke or systemic embolization and the major bleeding. And as we can see, either in both arms of odoxaban arm, they showed that less incidence of stroke or systemic embolization in comparison to warfarin. Also, the benefit appears in the major bleeding in both doses. And at the end, the primary clinical outcome are in favor of odoxaban in both doses in comparison to warfarin, and they have a nice conclusion. Compared with warfarin, higher dose odoxaban had similar rate of stroke, systemic embolization, and major bleeding in patients with biprosthetic valve. There was no evidence of effect of modification by the presence of biprosthetic valve for stroke or systemic embolization or major bleeding. For the net clinical outcomes, the effect of higher dose odoxaban versus warfarin was greater in patients with biprosthetic valve when compared to the effect in patients without biprosthetic valve. The effect of higher dose odoxaban versus warfarin on the net clinical outcome in patients with biprosthetic valve was also greater than in patients with valvular heart disease but no biprosthetic valve. The absolute event rate among patients with biprosthetic valve were very low. Now, let us move to the more recent indication is about patients who will undergo TAVI. And this is called Envisage TAVI AFib. This trial just recently published in Elastic ECC Congress in 2021. Odoxaban versus vitamin K antagonist for atrial fibrillation after TAVI. As we know, approximately 33% of patients post-TAVI present with prevalent or chronic atrial fibrillation. And the evidence for various antithrombotic strategy for AFib after TAVI is typically not studied. That's why in this trial, they try to look for the objective and the trial objective and the outcome to compare the efficacy and safety of odoxaban versus vitamin K antagonist in patients with prevalent or incident atrial fibrillation, and they have an indication for chronic anticoagulant therapy, and after successful TAVI. The primary efficacy outcome with the MACE, and the primary safety outcome with ISTH defined major bleeding. This is the study design of the trial. Patient undergo TAVI with or without severe complication and randomization. Patient will be randomized from the evening of TAVI to 5 days or up to 7 days if they have permanent pacemaker into odoxaban 60 milligram per day with or without antiplatelet therapy versus vitamin antagonist with or without antiplatelet therapy. The odoxaban was reduced in 30 milligram, as we know, in patient AFib with creatinine clearance 15 up to less than 50 milliliter per minute and the body weight less than 60 kg. The antiplatelet therapy was allowed for as per treating physician preference, that up to 3 months or single antiplatelet therapy indefinitely. For the primary efficacy outcome and the component, we have that we can see that there is a reduction of ischemic stroke in favor of odoxaban. However, the incidence of major bleeding was more in the odoxaban in comparison to vitamin K antagonist, and the bleeding was mainly GIT bleeding. Moreover, if we look to the outcome by dose adjustment criteria, either higher dose or low dose, and as we can see in both those adjusted criteria, the incidence of stroke or intracranial hemorrhage were the same, either patient according to adjusted dose or no, in favor of odoxaban in comparison to vitamin K antagonist. However, still the major GIT bleeding is a major problem in the odoxaban arm. What about outcome by specified oral antiplatelet therapy? It makes no difference. The ischemic stroke and the intracranial hemorrhage were less in odoxaban arm, but still the major GIT bleeding were more in odoxaban arm in comparison to warfarin. And the result overview, the non-inferiority criteria met for MACE primary endpoint. Higher rate of major bleeding with odoxaban were driven by major GIT bleeding. One major GI bleeding was fatal in the odoxaban arm. The rate of intracranial hemorrhage or fatal bleeding were similarly rare in both trial arm. Patients who fulfilled dose adjustment criteria and received odoxaban 30 milligram had similar MACE and the major bleeding rate as compared to patients with vitamin K antagonist. Among patients with pre-specified antiplatelet therapy, odoxaban was associated with higher rate of major bleeding compared to vitamin K antagonist. As we can see, the result is encourageable, but still we have to take it with some caution. And the conclusion from this trial, in the envisaged TAVI AFib trial, in patient with indication for oral anticoagulation who has an atrial fibrillation after successful TAVI, odoxaban was non-inferior to vitamin K antagonist for the composite primary composite outcome of adverse clinical event. In this patient, odoxaban was associated with higher major bleeding risk in the overall population. Sub-analysis suggests that the patient fulfilling those adjusted criteria and the patient without concomitant oral antiplatelet therapy may be reasonable and appropriate candidate for odoxaban based on attenuating bleeding difference versus control. Further investigation into these topics, of course, need to be studied more and are underway. So, my dear colleagues, in summary, novel oral anticoagulant offer benefit for patients with atrial fibrillation and VTE. They are as safe as and probably safer than warfarin. They are associated with lower risk of intracranial bleeding than with warfarin, lower risk for major bleeding for some novel anticoagulant. Trial data and real-world experience are accumulating. Need clinical outcome to balance the benefit with risk and long-term anticoagulation. Novel anticoagulation should be seriously considered for prevention of thrombosis, especially in very high-risk patients, as we showed in my presentation. Then, thank you so much for your attention, and I hope that I deliver the message in a clear way.
Good evening, ladies and gentlemen. First of all, I would like to thank Dr. Omar Halak for asking me to give this talk on a very important clinical topic, which is prostatical endocarditis. Prostatical endocarditis is one of the most challenging situations a cardiologist can encounter in their clinical practice, and typically endocarditis involving the prostatic wall can affect nearly 1 to 6% of prostatic wall and has got a very high mortality and morbidity, particularly related to the infection of the extension of the infection in the paravalvular area and the tissue embolism, which can affect practically all circulation of the human body. The current European Society guidelines, which came out 2015, are actually based on the modified Good's criteria, which includes positive blood culture of the typical organisms involved in endocarditis and involvement of endocardial involvement as seen by the vegetations on the echocardiogram. However, the European Society in 2015 put two additional major criteria, which includes abnormal activity seen by anatomical imaging, which gives rise to the metabolic information, such as the PET scan or the radio-labeled WBC on the SPEC scan, or a palpable leak by cardiac CT scan. In addition, they included as the minor criteria identification embolic event or infection aneurysm by imaging only. So the echocardiography plays a central role in the diagnosis of endocarditis, because it can point the endocardial involvement very clearly and delineate as the tissue destruction in the perivalvular area. You can see the vegetations, you can see the abscess, and you can see the pseudoaneurysms in the perivalvular area, and so is the major criteria, which is actually new dehiscence of prostatic wall. Vegetations in the case of prostatic endocarditis can be seen by transthoracic echocardiography as well as on transesophageal echocardiography, as the mobile masses which are attached to the annulus or to the leaflets in the case of biological walls. But sometimes, rarely, you can see vegetations at a remote area, which is at the site where the jet hits the other tissues. For example, in this patient, which has got a biprostatic aortic wall, and you can see the vegetations are in the ascending aorta, where the jet of the wall of the valve is hitting the ascending aorta. Transesophageal echocardiography is certainly superior to that of the transthoracic echocardiography. The yield of transesophageal echocardiography is in the range of nearly 92%, which is double that of transthoracic echocardiography, and that is because we can see the transesophageal echocardiography has got a spatial resolution to the tune of 1 to 2 millimeters. In addition, it avoids the artifacts which are induced by prostatic walls by transthoracic echocardiography. In a clinical setting, a new paravalvular leak can indicate a prostatic wall endocarditis. Like, for example, in this patient who had an aortic wall implanted nearly 8 months back and came to me with a history of fever and the positive blood culture, and the transesophageal echocardiography shows a paravalvular involvement in the posterior aspect of the aortic wall, and this jet is actually going down and into the left ventricle, and this also can indicate a prostatic wall endocarditis. TE can give us excellent spatial resolution, can show extension of the tissue infection. It can identify the pseudoaneurysms, which are nothing but an equidense or the equolite paravalvular structures, which can indicate the filling with the abscess cavity. And when this abscess cavity empties in the intracardiac chamber, what you get is a pseudoaneurysm, which is the pulsatile mass in which the blood can be seen going inside and outside the abscess cavity. So this is a pseudoaneurysm. In addition, another major criteria is a new dehiscence of a prostatic wall. Like, for example, in this patient, you can see there is a dehiscence of the prostatic wall and there is a severe aortic regurgitation. So this patient came to us with a fever and the blood culture showed staph positive. And you can see there's a significant dehiscence of the prostatic wall and the whole prostatic wall is rocking with a severe paravalvular leak. And this patient, surgeons refused to accept him and the patient succumbed to his infective process. In addition to the two-dimensional echocardiogram, three-dimensional echocardiogram also is important and it plays a role in the localization and the diagnosis of prostatic wall endocarditis. You can see a structure which is very, very clearly seen on the three-dimensional echocardiogram. The advantage of 3D echocardiogram that we can appreciate the full extent of the vegetation, and the size of the vegetation determines the embolic potential. So typically vegetation which is more than 3 centimeter in the long axis dimension in the absence of embolism makes is by the European guidelines as an indication for surgery. So it is very important to see the extension of the paravalvular extension of the infection, prostatic wall dehiscence, and the wall perforation. So the T is 3D T is more important than the 2D echocardiography. So the current European guidelines, they say in the context of the modified use criteria. So when you have this one, you can have a patient with a definite endocarditis or a patient with a reject endocarditis. But unfortunately, in the real life, in the clinical practice, a big chunk of patients fall in the category in which we cannot either definite put it or we can exclude it. So they're in the intermediate category. In this case, the European Society says that in the setting of prosthetic wall, we have to actually look at certain advanced imaging technique. And this advanced imaging technique includes the use of the PET scan by using the tracers FDG or with the WBC labeled SPECT scan and the cardiac CT, and look for imaging for embolic event by doing a whole body contrast CT angiogram. So what is this newer techniques which the European Society of Cardiology is talking about? One important technique they talk about using the 18-fluorodeoxyglucose PET CT scan, SPECT scan. So the idea is that these scan, the tracer will accumulate at the size of the infective process in the time-dependent fashion. But the only disadvantage is that we have to have an endocarditis which is kind of remote, so it cannot be used in the first 3 months because the inflammatory tissues can also accumulate the FDG glucose. And the second thing is that we have to separate from the normal uptake of the myocardium. That means the patient should be given the fatty food, high glucose food, at least 2 meals 4 hours before, and should be fasting 4 hours. So in that case, the FDG PET scan, particularly when coupled with the SPECT scan, can show periprosthetic soft tissue with intense metabolic activity at the wall ring, thereby raising the suspicion of the prosthetic wall endocarditis. Another technique which is very commonly and used is the use of radio-labeled leukocytes. Radio-labeled leukocytes obviously requires the involvement of the nuclear scan laboratories at site. So the medium-level autologous labeled leukocytes accumulate at the infected area in the time-dependent fashion. So this accumulation occurs more in the late phase of the scan than the earlier phase. And such a technique is far more specific for the detection of endocarditis than the PET scan on the CT scan. So you can see in this patient, we thought that this patient had got a prosthetic wall and this may be the source of the fever, but the radio-labeled WBC showed it is not the mitral wall, but it is the tricuspid wall, which is the source of the endocarditis. So it is very, very useful for the discrimination that endocarditis is coming from which wall, particularly whether multiple walls implanted in the same patient. Another technique which the European Society is recommending is multi-slice cardiac CT. So the multi-slice cardiac CT has got multiple advantage. First of all, it can show the coronary status for the patient which are planned for cardiac surgery. Second of all, it can show the extension of the tissue infections on the surrounding area. It can show the paravalvular leaks. It can show the pseudoaneurysms, and it can show the abscess cavities much more clearly than with the conventional techniques. And the number of papers have been published to show that the utility of the multi-slice cardiac CT is as high as the 3-dimensional echocardiography. And the European Society of Cardiology recommend that we can do the scan, and the advantage that this data can be transmitted to an expert and the data can be read in a more structured and the formal pattern. Once the diagnosis of endocarditis is made, we have to actually think what is to be doing. So over these years, the technique and the diagnosis and the therapeutic for the endocarditis has changed. So the prosthetic wall endocarditis suspicion, imaging, transthoracic echocardiogram is not the one which is recommended tool. The transthoracic echocardiogram is far more sensitive and specific. And then in the case of difficult diagnosis, the European Society recommends FDG PET scan and CT scan, radio-labeled WBC SPECT scan, and the multi-slice CT. And remember, the endocarditis, if any doubt, should be managed, particularly in the setting of prosthetic wall, in the expert center of excellence, which have an infectious disease team, because now we have newer organisms such as Brucella, Coxella, and there should be endocarditis team. And most important thing is not to forget the clinical context. Once the diagnosis of endocarditis is made, nearly 60 to 70% of this patient, they require some form of surgery. And so the most important thing for the clinician minds after diagnosis is made, what can be the optimal time for surgery? We want to do surgery as early as possible before the tissue destruction takes place. But at the same time, in the early phase, the tissue is friable and the bacterium is high. So the time comes, we have to sue on the clinical judgment with what is the optimal timing for the surgery. One of the most common points for surgery is the heart failure, uncontrolled infection, and the prevention embolism. And embolism typically when the vegetations are more than 3 centimeter in any axis, or in the presence of embolism more than 1 centimeter, and endothelial infection, particularly continuous positive cultures, and heart failure. In fact, heart failure account for nearly 50 to 60% of reasons for surgery. With this, ladies and gentlemen, I come to the end of my talk, and if there are any questions, I'll be happy to answer them. Thank you very much for your kind attention.
My name is Steve Jenkins at Ochsner Medical Center in New Orleans, Louisiana. It's a pleasure to be with you today and to be an honor to be invited to this meeting. I'm talking on IVC filter indications and complications. I have no conflicts that are germane to the content of this talk. The story of IVC filters starts where I work, and this is Ochsner Medical Center in New Orleans with Alton Ochsner, who started, one of the 5 members that started this facility. When he published this paper in 1970, touting the benefits of complete vena cava interruption in the middle and on the right compared to inferior vena cava plication. He stated that there was more persistent edema with plication compared to ligation. I don't quite understand that, but I do understand less pulmonary embolism when you completely transect the inferior vena cava versus plicate it, as he showed in his data. So the solution to this was the Mobin-Uden filter, which looks much like the strainer you put in your dish sink to strain debris. But the problem is that they became occluded with thrombus. So enter into the picture a man named Kimmel, who was an oil field engineer in Houston, Texas, which used this contraption in the upper left to filter debris out of the pipes pumping oil out of the Gulf of Mexico. He and Greenfield got together and created the Greenfield filter to mimic this oil field strainer to collect debris at the center of the lumen so that there would be more flow around the outside. But again, it was fraught with complications such as thrombosis of the vena cava. So this was given a class 3 indication or contraindicated in the United States. Now, not until the year 2000, when retrievable filters appeared on the market, which had a different implantation technique so that they could be removed, did the FDA downgrade the risk of IVC filters from a class 3 or contraindication to a class 2. This permitted more readily market approval, and several retrievable filters hit the market in the United States of America. So now if you look at this timeline, the 30-year filter usage in the United States was almost nothing until this retrievable filter hit the market, you see with the arrow. And after that, there was an exponential climb in IVC filter placements such that by the year 2012, there was almost 260,000 IVC filters implanted in the US, and many were for prophylactic reasons, which were not approved. And this came with a host of complications you see listed here that include perforated IVCs, occluded inferior vena cavas. Here you see one in the tricuspid valve. Here you see one being surgically removed from the gut. Here you see one perforating the gut. And here you see one in the tricuspid valve being removed with open heart surgery. So that led the FDA in the United States in 2010 to publish this letter where 921 device events were reported, and they listed migrations, embolizations, perforations, fractures, and they concluded that the physician responsible for placing a retrievable filter should be responsible for removing that retrievable filter. No duh. Now, I know a lot of you guys in this virtual meeting are sitting on your smartphones, so I want you to punch IVC filter. If you do that on your favorite web browser, the first 3 to 4 hits you will get are from some attorney trying to sue a physician for implanting an IVC filter. And if you read their wording, it will have exact wording extracted from that FDA advisory letter. Large redesigned IVC filters have been implanted in more than 65,000 patients. The FDA has concluded that risk of injury outweighs any potential benefit, allowing IVC filters to remain implanted. And then about the 3rd or 4th click on the attorney's site, it will pop up. Click yes or no to chat. We will help you. Now let's look at the data we have randomized, only 2 trials in the United States for IVC filters. The PREPIC trial was published twice, a 2-year results in the New England Journal, the 5-year results or 8-year results was published in Circulation. It was a 400 patient study with a 2x2 factorial design. Patients randomized to either unfractionated heparin or low molecular weight and randomized to either filter or no filter. Importantly, they were all given parenteral anticoagulation for 8 to 12 days, and then they were all required to take vitamin K antagonist for 3 months, and they were followed at 2 and 8 years. I want to show you the 8-year results. Importantly, half the people in both groups remained on oral anticoagulants for the extent of this 8 years. The primary endpoint of this randomized trial, one of only 2, demonstrated that patients who had IVC filter placed had a reduced incidence significantly for pulmonary embolism, an increased incidence significantly for deep vein thrombosis, with absolutely no cost of excessive mortality. The PREPIC-2 trial was done by the same group and was published in JAMA in 2015, but it was retrievable filters. They looked at both their 3 and their 6-month outcomes. Recurrent pulmonary embolism and death were not significantly different in either group. At 3 months and at 6 months, as you can see here, with insignificant p-values. So, if we look in the ACC AHA guidelines published in April of 2011, we can look at recommendations for IVC filters in the setting of acute PE. IVC filters are recommended with class 1 indications with 1 randomized trial. It's a 1B indication as patients who have pulmonary embolism with contraindication to anticoagulation. You can also see that patients who have either breakthrough events on anticoagulation or have issues with anticoagulation, you still get a class 1 indications, but they're mostly expert consensus. The recommendations for IVC filters for iliofemoral DVT are almost identical as those for PE. You see them listed here. I won't regurgitate them. And if we look at multiple societies' recommendations for IVC filters, I want you to look across the top. There's ACC, there's American College of Chest Physicians, Radiology Society, European Society, British Society, and Eastern Association of Trauma Surgeon Society. What you should note is that only 2 societies, SIR and the surgical societies, have recommendations. Ours recommended, NR's non-recommended, a dash is no position. But only those 2 societies, and they've recently upgraded their recommendations in the Radiology Society, the Society of Interventional Radiology, so that there's not as many of these. But they're the only 2 societies that have prophylactic use for IVC filters where they're recommended. If you look at who recommend, what indication filters are recommended for by all societies, it's contraindication to anticoagulation. And you also see there's still a lot of recommended for failure of anticoagulation, breakthrough PE despite anticoagulation, or issues with anticoagulation. You still get a lot of recommendations. Where they're not recommended is pulmonary embolism undergoing thrombolysis that cause more harm than good, or adjunct to therapeutic anticoagulation. They have more harm than good.
Hello everyone, my name is Razan Halak. I'm a registered dietitian and I'm here today to talk about the keto diet. Our objectives for today include discussing the origin of the keto diet, explaining the relationship between keto diet and weight loss, comparing healthy dietary recommendations to keto diet, and finally identifying consideration related to heart health. The keto diet was first used by Russell Wilder in 1921 as a therapeutic diet for pediatric patients with epilepsy to help with seizure control. Currently, it's being studied for Alzheimer's disease, brain cancer, and weight loss, and many other health-related conditions. The point of following a keto diet is to put the person in a ketosis state, which means that their body is using fat instead of carbohydrates as a fuel for energy. There are multiple ways of someone can be following a keto diet. The classic keto is very restrictive, only allows 4% of the caloric intake to come from carbohydrates, 6% from protein, and the rest 90% of the calories come from fat sources. The popularity of the keto diet in the general population comes from the rapid weight loss that people start to see once they start following a keto diet. A lot of research showed that the weight loss at the beginning of the journey comes from water loss that is associated with the carbohydrates. Once the person is in a true ketosis state, which means they are using fat for energy, the weight loss starts to slow down and they won't be able to see a lot of weight drop as they were seeing at the beginning. And they really need to maintain this state to be able to continue their fat loss. Another point that I wanted to highlight is the restriction of this diet. If someone is following a restrictive diet, they will be losing weight just because they have to make a lot of dietary changes. They would be eating less with more restrictions, and therefore they will be losing weight because they are eating less. And the keto diet is very restrictive, so that is another reason they can start to see more weight loss. For someone who's following a keto diet, there are several health dietary recommendations that they need to be concerned about. Fruit intake is really something that I wanted to focus on because for the keto diet is really low in carbohydrates, and fruits tend to be mostly higher in carbohydrates. If someone is following a keto diet, they will be limited to how much fruits they can add to their diet, and therefore they might be missing a lot of important vitamins and minerals. They will also be missing the amounts of fiber they need to be consuming on a daily basis. Fiber has been shown to be very important for heart health. Higher intake of fiber is associated with a lower risk of heart diseases. And therefore, if someone is not eating enough fruits, they really need to be learning about other sources of fiber and how they can add more fiber to their diet to have the benefits of fiber on heart health. The other point I wanted to talk about is fat. Because the keto diet is very high in fat, whoever is following a keto diet, they need to have a solid understanding of fat intake. We have 3 different types of fat. Saturated fat, which is solid at room temperature, and it is mostly comes from animal sources. It is recommended by the American Heart Association to be less than 5 to 6%. And this is really recommended for heart health and better healthy diet recommendation. The unsaturated fat is liquid at room temperature and mostly come from plant-based sources, and this is considered to be a healthier fat. So for someone who's following a diet like the keto diet that is very high in fat, they need to have a solid understanding and good knowledge about what kind of fat they are eating and how much of each kind they are eating, so they can make a balance and don't harm themselves and their heart. Other than the amount and the type of fat that someone on a keto diet is following, they need to be concerned about the genetic predisposition, because this play a really big role in heart disease. If someone have a very heavy family history with heart diseases, starting a keto diet will even increase their risk of having a heart problem even more. So this is a very important point to mention for the healthcare provider. If someone is planning on starting a keto diet and they have a family history of heart disease. The other point that I wanted to highlight is long-term effect. Research is really limited on how much information we know for someone who's following a long-term keto diet. The main reason why this is we don't have a lot of information about this topic is because the sustainability of this diet is very hard. Most people who follow a keto diet need to be making a lot of changes to their dietary habits, to their social events, because we're using fat instead of carbohydrates for energy, the energy will be changing a lot for someone who's following a keto diet very strictly. So for most cases, it's not sustainable for a long time, and studies just can't be recruiting a lot of people to do more research on long-term effects. So this is just an important point to keep in mind. Another thing, and this is the last point that I wanted to just mention, the keto diet is a restrictive diet, as we said before, so it can be a trigger for eating disorder or disordered eating. People who have any problem like GI problems, this can have other side effects on it also, just because the fat is really high and it might be consumed or digested, absorbed differently for people who have the GI problems. People with diabetes, liver diseases, or kidney diseases need a lot of focused healthcare supervision to make sure that they are not having side effects on other organs in their system. Thank you so much for watching. I hope you enjoyed this presentation. For any questions or discussion, I would be happy to receive any emails on my email, razanhalak@outlook.com. Thank you so much.
Hello, my name is Dr. Lauren Barron. I'm a physician and clinical professor at Baylor University in the heart of Texas, and I'm the proud director of the Medical Humanities program here and the holder of the DeBakey Chair of Medical Humanities, and I'm delighted to be able to introduce you to a figure that I think is very important for us all to know about, to read, to understand his contribution to medicine, and that is Dr. Eric Cassell. And I've titled my talk, Dr. Eric Cassell in the Heart of Medicine today, because I believe that he really did contribute to our understanding of what is at the very heart of medicine. I took these photographs at his home in Pennsylvania, where he retired after over 35 years of practice of internal medicine in New York City. I thought you would enjoy the heart next to the metronome. He was a fan of music as well as medicine, and also the stethoscopes that were a treasured tool of his trade. Dr. Cassell was a champion of clinical medicine. He believed very strongly in how important it is to be excellent at history taking, and also the importance of careful observation during the physical exam. He was an early advocate for the person of the patient, to not think of the patient as if they were a person, but to consider them as they were, as persons in their whole entirety. And he was a leading figure in American bioethics, and I think a real treasure and a source of wisdom that we should be reclaiming today. While you look at his timeline, you can see he's from New York City and where he trained, and up until the early part of his career where he published The Healer's Art. You're able to look at that, but I want to tell you a little bit about a story that influenced him early on that he wrote about in the prologue of The Healer's Art, and I'm going to read a little bit of that to you now. Many years ago, while in residency training at Bellevue Hospital in New York City, I had a midnight call from the psychiatric ward. An old woman was having difficulty breathing. I found the patient gasping for air, her skin blue. She had full-blown pulmonary edema from a blood clot in her lung. I sent the nurse for the urgently needed oxygen and drugs, but in those days, because of staff shortages and inexorably slow or inoperable elevators, a critically ill patient on a psychiatric ward in Bellevue at midnight might just have been in the bottom of the East River. The wait for the necessary equipment would be interminable. I stood at the bedside feeling impotent, but the old woman's face in her distress pleaded for help. So Dr. Cassell began to talk calmly about what was going to happen, what was causing the fluid in her lungs, explaining that she would gradually start to feel the fluid receding from her lungs, and that she was going to feel better, and that she needed to relax, and the tightness of her chest would gradually resolve. And to his utter amazement, he says, that is precisely what happened. Not only did her fear subside, but the noises in her chest disappeared under my stethoscope, giving objective evidence that the pulmonary edema was in fact subsiding. Now, you need to understand that Dr. Cassell was a believer in empirical science and proof and observation, and he spent the rest of his career trying to understand what was it that happened between he and the patient that day. There was something about the connection they had, something about the relationship they had that allowed him to be able to be a healer for this woman, even though he didn't have the tools or the techniques or the technology that he thought that good doctoring required. So it was more than just technology, and he spent his career trying to understand that. So this is The Healer's Art that I commend to you. It was published in 1976, his first book, and it made quite a splash. It was unlike anything else that was being written at the time. Another thing I really appreciate about Dr. Cassell, and this is also from The Healer's Art, is the idea that there are other ways of knowing besides science. So what he says here is that the method that we use to get an answer determines the nature of the answer. If we were asked to describe a rose and we were only given a ruler to do it, the picture that emerges of that rose is going to be true. It's going to be accurate, but it's only going to be in terms of inches. And that is going to leave out a lot of what we know and experience about roses. If we tried only to quantify the information and we only took quantifiable information into account, we would be missing out on of medicine, published in the New England Journal in 1982. And in this article, which I don't have time to read from for you, he talks extensively about the difference between suffering and pain. Those concepts apart and helped us understand that more thoroughly. He also talked about the fact that much of what we do in medicine actually causes suffering, and that we need to be attentive to that. And he also
All right. We had such a great lecture there with Dr. Barron, and had some technical difficulties there, and I apologize for the whole team on that one, because that was truly the heart of our conference, with regard to the heart of medicine and how we approach our patients and help them make it through their illnesses. I want to thank all of our speakers, such excellent talks there. And I think Dr. Halleck may be joining us, but I want to start with some questions or comments, actually, on some of these great lectures. Dr. Mahapatra, the PET scanner, the PET CT and PET SPECT, I guess. It's such a great help for us here in the U.S. And I think you are, I believe, you are in India? Are you in India?
Yes, I'm in Mumbai.
Right. So in the UAE also, I think there's a lot of work to be done with regard to that to help us really evaluate those patients. And I think Agarwal talked about in prosthetic valve endocarditis as well. So great information about the PET. You all want to comment a little bit more about that? The need for that. I think, are you all, I can't hear you.
Yeah, Dr. Mahapatra, anybody is asking, what is the role of the PET scan in what is the role of PET scan in the case of endocarditis? This PET scan is one of the important tools in the endocarditis, and probably you can throw more light on it.
Yeah, already I have shown the slides, Dr. Ani. I have shown that if there is a prosthetic valve endocarditis, which Dr. Amrish spoke, and yes, definitely it has got a very good role. Even one of my press cases which I showed, there is a pacemaker infection in the right axillary region. So that we could detect, and the patient was having rigor, chill, fever, and everything, and all. They were changing from one antibiotic schedule to another antibiotic. Then they came to us. Then I put the patient, as Dr. Amrish had rightly pointed out, on a high protein, low carbohydrate diet. And on the day of the test, we use unfractionated heparin, which raises the fatty acid level, so that it will be on the fatty acid substrate. So we could pinpoint the focus of the infections, and the patient was given, was operated, and they curated lot of dead, inflamed, necrotic tissue from the right axillary regions, and then they put the antibiotic, and the patient got cured, and there was no fever. So similarly, in prosthetic valve endocarditis, I have a comment on Dr. Amrish. See, what I was mentioning about, that suppose a patient came, your transesophageal echocardiography, whatever you did not, if follow-up case of prosthetic endocarditis, Dr. Amrish, you did not find any vegetation. But still, the patient is having fever. Whether how you diagnose the metastatic focus anywhere in the body. You cannot do a whole body MRI. You cannot do a whole body CT. If you do a whole body PET CT scan, then you can pinpoint the metastatic focus anywhere in the body apart from the prosthetic valves. Then the antibiotic can start. Usually, the cardiologists, they say vegetation, start with antibiotic. Then they cure the patient. Patient used to go home. Then patient comes back. Another focus is there in streptococcus hemolyticus infection anywhere in the low down, in the pelvis or anywhere. So in that case, the PET FDG has got a big role to diagnose the metastatic complications or metastatic focus of infections of the prosthetic valve anywhere in the body.
You have Dr. Mahapatra rightly pointed out, if you want to distinguish between cardiac and extracardiac infections, then the PET scan is the way to go. But in our clinical practice, what we have seen is that when the patient has got multiple walls, for example, somebody's got a mitral valve and aortic valve, and there's an infection and the T is negative, and we are not able to pinpoint which one is infected, then we find that the nuclear lab in the form of a radio labeled WBC can be very specific in pinpointing which valve is involved. So these are the new imaging modalities with the European Society, and these are molecular imaging, like you said. The European Society is asking us to incorporate this in our routine clinical practice. So thank you very much, Dr. Annie, to bring it out.
I think that this is highly important, you know, for the clinical cardiologist out there in you know, the world. I mean, we don't have often access to all of these things, but to know that this is available and to know that there are centers of excellence. Even that's why I was asking Dr. Halak, you know, about in the UAE with regard to availability of this kind of modality. I think there's a lot of room for improvement on that. And so we thank you for sharing that with us. I want to take it over to Dr. Salah. Very interesting information about NOAC, right?
Yes.
Because this is up and coming. How do we treat these patients? And you elegantly outlined that for us. Do you want to, your take-home message on that, I think, is if patients are having these other problems that you outlined, you know, not just atrial fibrillation, we can now safely look toward using NOAC in those patients, I believe.
Thank you. Thank you so much for this nice word. I hope that my message was clear. I hope.
It was very, very clear. Thank you. Thank you. Now we have just a few more minutes. Dr. Jenkins, you're back with us. Dr. Frazier has arrived, my great teacher, my mentor, my friend. And I don't know where Dr. Halak is, but gentlemen, we missed all the peripheral stuff. So this is the end of the conference, and we just want to see what you all have to say about that. Before you speak, I want to thank Razan coming in front of all these interventional cardiologists. You nicely outlined the keto diet, and thank you. And Dr. Barron is not here, but her talk was really excellent on the heart of the matter. Dr. Frazier, what do you have to tell us?
Thank you.
Well, number one,
great presentation.
Thank you very much for organizing this particular session. As always, you have done a tremendous job. Unfortunately, I couldn't hear most of it because I was involved in Hall C. We have completed actually our excellent session in Hall C, and Steve Jenkins was there as well with his excellent presentation, as well as all the leaders, world leaders in the field of endovascular intervention. It was another great success for 4Ts. I'm hoping that Omar will be able to join you shortly.
Yes.
I don't know, Annie, are you in Dubai or are you in Houston?
I'm in Houston. I'll be in Dubai soon, so I feel like I'm in the air all the time.
Well, yeah, I'm waiting for Omar to join us for closing remarks. But while we are waiting for it, I did not have a chance to ask Steve Jenkins or a comment on his excellent presentation on endovascular treatment of vertebral artery disease. Steve, this was very, very informative. And one remarkable thing, I think all of the presenters here are cardiologists, and I know you are a cardiologist, so it is uncommon for cardiologists to do those type of interventions. Ashner Clinic is one of the unique centers where this has been done for a very long period of time, and you guys gain a lot of expertise. This is particularly in the domain of a neurointerventional radiologist. So tell us briefly, just in a few sentences, how did you gain interest and expertise in this field that is really challenging and almost completely reserved for neurointerventional radiologists?
Thank you very much for being invited to this conference. And I can answer that in 2 sentences, but my first sentence wanted to tell you that I was in Hall C on this computer while I'm on Hall C and Hall A in the computer that you're on. So you can do it actually with 2 computers. Your login allows you to. So I listened to both conferences. To answer your question, I know you know probably a man named Joe Murgo, who started the Ochsner Cardiology Group back in the day with Chris White, Steve Ramey, and Ty Collins. I was number 4 to be added. At that time, he had the concept of the subspecialized cardiology, where he had a few interventionalists that just did intervention all day, a few echocardiographers who just did echocardiographers all day, such as the way you see cardiology is going today. So we actually did stroke intervention until about 5 or 6 years ago, until we got our neurointerventional radiology group at Ochsner. And so I participate with Chip Sternberg and the CREST II randomized trial. We've participated, as you know, Chris White has been one of the PIs of one of the, I believe, the Beach trial, the carotid trial. So we have been in this headspace since the beginning of time. And we go basically where blood goes, actually. So that answers your question. But thank you for the kind comments, and Dr. Halleck for the opportunity to be in this world-class group of people, which maybe I feel like I don't belong in, and you've accumulated in the midst of a pandemic. Congratulations.
Thank you so much. I really enjoy your talk, and I really appreciate your being with us here. And hopefully next year we'll have you and all the speakers here with us in Dubai. And it was really a wonderful meeting with the presence of all the renowned faculty from around the world. And it was really, I really personally enjoyed this conference myself, and I learned a lot. And as Steve mentioned, actually I have 3 holes. I'm jumping between those 3 holes back and forth, and it was really because there is so much information and thing you can learn, and you don't have enough time to learn everything here. But
well, you need 3 computers, and you won't have to jump between any of the holes.
We have to have 3 sets of eyes and 3 sets of ears. But it was really good. Actually, it was I was able to catch most of the stuff in different holes. It was really kind of interesting, and I'm glad we do it virtually. Otherwise, if we have to do it physically, I'll be on the scooter running between holes.
Like we used to do.
Dear Omar, we are coming to the end of 4Ts, and before we conclude, I would like to say personally, this has been one of the best meetings that I have participated, particularly as far as virtual meetings are concerned. Praveen and his team, and you have done a tremendous job. Number one, we have a world-renowned faculty. Some of them are here and some of them are not. But this is a great success. The presentations were very informative as far as educational component is concerned for the beginners, but also related to the latest advances in endovascular field and also surgery. So I would like to congratulate you in being able to attract attention of the world leaders in this field. It is my personal honor and pleasure to be working with you for 9 years. Actually, this is the 8th year for the 4Ts, but we've been working on it for 9 years to make it happen. And we are growing, getting better, and we have actually desire to expand it even further, not only virtually, but in presence of all the faculty that are here and more to come in the near future. So from my point of view, I think it was another great success, and thank you very much for your friendship and for your expertise in organizing 4Ts.
Well, thank you so much. I cannot thank you enough for all your help and support all along for the last 9 years. And with you, it was a very successful meeting, and I'm glad that we were able to get this conference together, and it's getting better every year. And I hope we continue to grow and get better quality and bigger, actually. And
Dr. Omar, I am with you for this meeting, and Dr. Salah with you in this meeting from the time of inception. And I can tell you what Dr. Krezek said, and you, both of you and the team, has been wonderful in raising this meeting standard to nearly an extensive, breathtaking spectrum of speakers in the field of not just clinical cardiology, intervention cardiology, structural heart disease, peripheral vascular disease. I think probably this is the largest meeting in the world, I will say, in the matter of in which all these components of whole cardiology, and likely you put the title 4 years from toe to the head, everything is involved. Fantastic.
We tried to fulfill the name, and I'm glad today Dr. Steve Jenkins gave us from intracranial And all the way, we have some people to talk about the toe intervention. So it was
Yes.
to fulfill this name actually. And next year, probably would like to put a session for intracranial intervention for special acute stroke management. We did once before. We have a team for purely for intracranial intervention, and hopefully we can plan for next year also. And so we try to fulfill this name, and hopefully every year we'll expand more and more and have more in depth. I really appreciate all of you because all the speakers contribute hugely to success of this meeting. And I really appreciate everybody. I cannot thank everybody enough. I cannot thank everybody for their part of the success.
Thank you so much.
Well, we look forward to seeing you all in Dubai next year.
After 3 very busy day, we have a kind of overdose of cardiovascular knowledge. It's time to now digest all those knowledge we have over the 3 days, and hopefully we'll have a little bit of rest. And especially Dr. Kreger has been, and Dr. Annie also has been 3 days non-stop running from beginning to the end. It's time to have a break, and I am looking forward to have all of you next year in Dubai. Hopefully, Corona will be a history, and we'll have a normal life. Thank you so much.
Hopefully. Thank you so much.
Thank you all.
Thank you.
Thank you.
Thank you,
Thank you, guys.
Family.
Have a good day.
Bye-bye.
Bye.
Awesome.
Thank you so much. Have a good night, and thank you, Dr. Mahapatra. It was great to have
Thank
you.
you.
And,
Thank you, Dr. Omar.
Your contribution
Yes,
was really
we'll
excellent, and looking forward to have you again. Thank you,
Yes,
and
thank
good
you.
night.
Good night.
Good night. Good night.
Bye-bye.
Good night, Dr.
Bye.